Okay, folks, we'll reconvene the Standing Committee on Public Accounts. We'll turn our attention. We had a brief break. I don't know if there's others. Well, I know there's others. I'm sure everyone in this room sort of looked at the world around us as we step away from this table. And, you know, I just thank everybody that's here and all these folks that are at this table and for your attention and your diligence. But, you know, it's hard to even get your mind around when you look at what's going on in Ukraine right now. And civilian assets and civilians and atrocities with human rights that, you know, I think that most of us thought we'd never see again. But anyways, I know it's hard. Yeah, I guess as the chair, I'm struggling to make sure you've got my full attention and you have it. But it would be wrong of us as well, I think, not to recognize that each one of us, you know, our minds are in part, I think, tracking the horrors and atrocity that's playing out right now. Anyways, thanks for everybody's time and attention here today. And I'll turn it over to our provincial auditor to focus in on Chapter 12.
Chapter 12 of our 2019 report, Volume 1, on pages 187 to 205, reports the results of our audit of the Saskatchewan Health Authority's processes to maintain healthcare facilities in the City of Saskatoon and surrounding area. This chapter includes 10 new recommendations. Over 50 healthcare facilities located in the City of Saskatoon and immediate surrounding areas serve over 360,000 Saskatchewan residents in more than 100 communities, which includes cities, towns, rural municipalities, and First Nations communities. Facilities located in the City of Saskatoon and surrounding area include 9 hospitals, 28 long-term care facilities, and 19 health centers and other healthcare facilities. Facilities include buildings and significant components, for example, boilers and air filters. The healthcare facilities located in Saskatoon and surrounding areas accounted for about $1.5 billion of the authority's estimated deferred maintenance, with an average facility condition index of 26%, which is a poor condition. Maintaining facilities to acceptable conditions helps ensure they meet service delivery requirements. Deferring maintenance can reduce capacity to provide services, increase future repair costs, and potentially reduce overall service life of facilities. For example, having to replace a building or components earlier than intended. Proper operation and maintenance of a healthcare facility and its key components, such as nurse call systems and boilers, is essential not only to the safe and effective delivery of health services to patients and long-term care residents, but also for providing safe work environments for healthcare providers. We concluded for the 12-month period ending November 30th, 2018, the Saskatchewan Health Authority did not have effective processes to maintain healthcare facilities located in the City of Saskatoon and surrounding area. We made 10 recommendations. While the authority has qualified staff and relies on their professionalism to conduct maintenance, it needs to make improvements in the various areas to effectively maintain its Saskatoon area facilities over their entire lifespan. The authority needs complete and consistent information about each key Saskatoon area facility and component subject to maintenance to provide a basis for maintenance planning decisions. It needs a comprehensive risk-based maintenance plan to guide maintenance decisions of those facilities and components over the long term. This would include setting desired conditions of key facilities and components and consistently setting the nature, extent, and expected frequency of regular maintenance. In our first recommendation on page 193, we recommend the Saskatchewan Health Authority establish measurable service objectives for its key healthcare facilities and critical components located in the City of Saskatoon and surrounding areas. Having minimum condition standards enables taking a risk-informed approach to maintenance planning. It facilitates comparisons of assets' current conditions to those standards to identify particular facilities or components at risk. This supports determining the extent of resources needed for maintenance and deciding where best to focus maintenance efforts over the short, medium, and long term. In our second recommendation on page 195, we recommend the Saskatchewan Health Authority control the accuracy and reliability of maintenance data in its IT system for key healthcare facilities and components located in the City of Saskatoon and surrounding areas. Insufficient controls over user access to the maintenance IT system and insufficient program change controls may result in system data being inaccurate or incomplete. Inaccurate and incomplete maintenance data may result in inappropriate maintenance decisions or using additional time unnecessarily. In our third recommendation on page 196, we recommend the Saskatchewan Health Authority maintain complete information on each of its key healthcare facilities and components located in the City of Saskatoon and surrounding areas to enable the preparation of comprehensive maintenance plan. Having a complete listing of key facilities and components provides the basis to decide on which types of assets to do preventative maintenance and on which to do only reactive maintenance. Not identifying all of its key facilities and components increases the risk that the authority may not effectively prioritize maintenance activities or make inconsistent decisions about approaches to maintenance. This could lead to increased future repair costs or replacing facilities or components earlier than intended. In addition, not basing planned preventative maintenance decisions on current and complete information increases the risk of maintenance inefficiencies. We found the authority needs documented guidance on prioritizing maintenance to support completing maintenance within scheduled timeframes. Timely maintenance reduces the likelihood of failure or breakdown, which reduces the risk of harm to residents, patients, visitors, and staff. In our fourth recommendation on page 198, we recommend the Saskatchewan Health Authority consistently set the nature, extent, and frequency of preventative maintenance activities for similar categories of key healthcare facilities and components located in the City of Saskatoon and surrounding areas. For 5 of 6 preventative maintenance requisitions we tested where the maintenance IT system identified a reason for the preventative maintenance, such as a requirement per a manufacturer manual, relevant Saskatoon area maintenance staff was unable to provide us with the related manual or other support for the basis of these preventative maintenance decisions. In addition, our testing of 30 preventative maintenance requisitions found the authority did not make consistent preventive maintenance decisions on the same equipment types. For example, facilities management decided to maintain nurse call systems located in Saskatoon on a monthly basis, whereas for 2 systems located in rural facilities, it decided to maintain them only when they failed. Not making consistent decisions and aligning the frequency and maintenance activities with standards, that's manufacturer and code requirements, increases the risk that key facilities and component assets are not maintained appropriately, or conversely, resources are used inefficiently. Inadequately maintained assets may put patients, residents, visitors, and staff at risk or injury if an asset fails. In our 5th recommendation on page 199, we recommend the Saskatchewan Health Authority use its planned maintenance activities as an input to setting its Saskatoon area maintenance budget. Since the authority has not set measurable service objectives, it has not estimated the cost to maintain its Saskatoon area assets to a desired condition or asset availability over its useful lifespan. As a result, the authority does not know whether it's doing maintenance at appropriate times, or if not, what the impact of deferring maintenance is on the delivery of healthcare, safety, and costs. In our 6th recommendation on page 200, we recommend the Saskatchewan Health Authority complete preventative maintenance on its key healthcare facilities and components located in the City of Saskatoon and surrounding areas within expected timeframes. For 30 preventative maintenance requisitions we tested, 14 were not completed within the time frame set out in the maintenance IT system. Staff completed expected maintenance tasks between 11 and 251 days after the scheduled maintenance date. For 4 of 6 roof inspections included in our example, staff completed the inspections between 14 and 251 days after the scheduled inspection date. Not completing timely preventative maintenance increases the risk that an asset may fail and cause harm to residents, patients, visitors, or staff. This could also lead to increased future repair costs or the authority maintaining assets earlier than intended. Our 7th and 8th recommendations on page 201 are related. We recommend the Saskatchewan Health Authority have written guidance for classifying and prioritizing requests for demand maintenance on key healthcare facilities and components located in the City of Saskatoon and surrounding areas. In addition, we recommend the Saskatchewan Health Authority complete demand maintenance in line with priority rankings for key healthcare facilities and components located in the City of Saskatoon and surrounding areas. For 7 of the 10 demand requisitions we tested, staff did not complete the demand maintenance work within the time frame consistent with the priority rating. For example, we tested 1 demand requisition with a priority ranking of 3, that being more urgent than other requisitions based on the urgency scale of 1 to 12. This requisition was for the installation of security at a lab exit for safety reasons, but maintenance staff did not complete it until 184 days after the initial request. In addition, 3 of 10 demand requisitions we tested were not repairs of components or equipment that did not work. Rather, the work was more of the nature of a capital project to replace or renovate components. Completing capital projects as a demand requisition allows staff to skip the prioritized process for capital projects. Not completing timely demand maintenance increases the risk that an asset may fail and cause harm to residents, patients, visitors, or staff. In our 9th recommendation on page 202, we recommend the Saskatchewan Health Authority consistently document the priority of capital maintenance projects undertaken in the City of Saskatoon and surrounding areas. Failing to score projects consistently or documenting rationale for selecting projects can lead to an increased risk the authority is not prioritizing and completing capital projects that best address its needs. In addition, it increases the risk of not using resources, for example, staff and the budget, effectively. Finally, we found senior management need to receive reports on results of Saskatoon area maintenance activities. In our 10th recommendation on page 204, we recommend the Saskatchewan Health Authority report to senior management the results of maintenance activities for its key healthcare facilities and components located in the City of Saskatoon and surrounding areas. Without sufficient analysis and reporting of maintenance results, the authority cannot assess if effective maintenance of its key facilities and components is occurring, or if maintenance funding is sufficient and efficiently used. I will now pause for the committee's consideration.
Thank you very much for the presentation and the focus of the work. I'll turn it over to Deputy Minister Hendricks for presentation, and then we'll turn it over for questions.
Okay, thank you. With respect to recommendation number 1 on page 193, the SHA considers this recommendation implemented. The SHA infrastructure team performed a high-level assessment of the Saskatoon area critical infrastructure in the fall of 2018, which informed the development of a capital budget for 2019-20. Work to develop it was delayed due to COVID-19. By December 31st, 2021, a provincial capital asset plan with measurable service objectives for all assets, including Saskatoon facilities and critical components, was completed. With respect to the second recommendation on page 195, the SHA considers this recommendation partially implemented. The SHA is currently implementing processes to control system access and utilization based on roles and job function. In addition, the SHA is implementing a software update to track all changes made in the system. Work on responding to this recommendation was put on hold as the SHA focused on responding to the COVID-19 pandemic. Responses to a request for proposals for a computerized maintenance management system are under evaluation. The contract is expected to be awarded by March 31st, 2022, and implementation is planned to be complete by March 31st, 2023. On recommendation number 3, page 196, again, the SHA considers this recommendation to be partially implemented. The SHA has created a work standard for entering facility information into its maintenance system and has verified that the information for 19 critical systems within the Saskatoon facilities is complete. The SHA will verify all information for key facilities and components in the Saskatoon area. Recommendation number 4 on page 198. Again, the SHA believes that this recommendation is partially implemented. Work on a project is underway to develop a standardized written procedures to describe the preventative maintenance of key facilities and components, including frequency, manufacturer instructions, and code requirements. Members of the project and working group are from across the province. In addition, the SHA will implement a work standard for preventative maintenance that includes assessing the condition of the asset and updating the asset record accordingly. Work standards will be validated and approved by building services directors each month. The project team expects to complete the work standards by October 31st, 2022. On recommendation number 5 on page 199, again, the SHA believes that this recommendation is partially implemented. It is developing a risk-based maintenance plan for a Saskatoon area key facilities and components, expected to be complete in the summer of 2022. Recommendation number 6 on page 200. The SHA considers this recommendation partially implemented. The SHA is developing standardized procedures for completion of preventative maintenance within the expected timeframes, as well as a tracking and escalation system to monitor the performance of their maintenance staff. The work is expected to be completed in summer 2022. Recommendation number 7 on page 201, the SHA considers this recommendation to be partially implemented. The SHA is developing guidelines to help its Saskatoon-based maintenance staff prioritize, respond to, and complete demand maintenance work requests. Recommendation number 8, the SHA considers this recommendation to be partially implemented. The SHA will use priority ratings for key healthcare facilities to plan daily work activities of its maintenance staff in the Saskatoon area. In addition to developing a reporting system to monitor completion rates and compliance to priority ratings, an escalation process for complete demand maintenance requests will be implemented. Recommendation number 9 on page 202, the SHA considers this recommendation to be implemented. In addition to consistent criteria and evidence to support decisions, the new capital intake process includes a review committee to ensure that the plan addresses complexity of issues and is aligned to investment strategies. This process helps to formalize and consistently document capital budget planning, including prioritization of projects. And finally, recommendation number 10 on page 204, the SHA considers this recommendation implemented. Monthly reports about capital budget execution and preventative and demand maintenance performance are provided to SHA senior management on a monthly basis beginning on December 1st, 2019. Thank you.
Thanks for the report and all the work on this front. I'll open it up to committee members for questions. Ms. Ritchie.
Well, that was a surprise, I bet. Okay, well, thank you both to the audit team for their presentation and responses from the Deputy Minister on the current status and the planned actions for each of those 10 recommendations. And I think it's just as a comment, it's not often that I see audit reports that start off with did not have effective processes. Typically, it's more in the case of they do, but here are some deficiencies. So that's concerning. And I guess my questions will try to understand what's behind some of that lack of effectiveness, and while at the same time also appreciating that you've obviously taken a number of steps here to address any deficiencies moving forward. So maybe I'll start with page 192, discusses the overall average facility condition index, and the 2018 numbers are noted. Is it possible to get updates for 2019, 2020, and 2021? And in addition to that, also a breakdown by facility. I note that in the listing of the Saskatoon and area facilities, I did see that here somewhere a moment ago. A very comprehensive list of acute care hospitals, health centers, and other facilities, and long-term care homes that are part of the facilities that are, I assume, to be included in the scope of this audit, and noticing in particular that a number of these are long-term care homes. Curious to know how, to the extent to which these maintenance deficiencies are impacting on more sort of acute care hospitals and health centers versus long-term care facilities.
Maybe I can start, and then I don't know if Andrew can maybe pick up where I leave off. And so your first question was regarding the facility condition index and if that would be available for more recent years by facility in Saskatoon. I believe we have the information to 2019. After that, we're looking at transitioning to a new facility condition system that SAS Builds is rolling out, and so we don't have it more recently than that. With respect to the other questions, I'll maybe turn it over to Andrew.
Yeah. So if I remember right, you were also interested in a breakdown by facility of FCI, and I think that does exist for the previous study, as Max indicated. In terms of the long-term care facilities, I'll just say, like, some of those in Saskatoon are operated by affiliate organizations as well. So there is a separation there. And maybe just a general comment to your point, your opening comment on the lack of standards. And I'll just say across the province, maintenance services, and I think the description that the provincial auditor gave was a good description in terms of really relying on kind of the professional judgment and work of maintenance leadership in terms of caring for the buildings that they're looking after. And I really do see an opportunity here to approach this in a more methodical, documented, consistent with standards way. And I really see that the formation of the SHA really lends an opportunity here for us to create that sort of professionalism in terms of how maintenance services are provided across the province. And in terms of how we've organized ourselves, maintenance services literally report up through maintenance leadership, specifically that have expertise now in that particular area. So while we had lots of variation before, we're working to standardize that. And as Max had mentioned, there's good work happening across the province to standardize our maintenance processes. And each week they're working through more and more types of equipment and establishing those standards. And then we're really excited about the procurement of the computerized maintenance software, because that will allow us to really quantify and track and make visible where we are behind on maintenance. So those would be my comments there. I think we'll be in a better place once that work is complete.
And just for clarification, can I take from that response that data up to 2019 can be provided as requested?
We'll provide that to the committee.
Okay. So you mentioned that post 2019, that SAS Builds would be providing some sort of a role. Could you please elaborate?
So the purpose of the facility condition index and that software was to track facilities across the province, so that we had a mechanism by which to allocate maintenance funding to various facilities, determine when a facility needed to be replaced, that sort of thing. I think the interest is in moving to something that will allow a more universal system across all public sector capital. So right now, the challenge is we have one that we use, or did have one that we use in the health system, but we need to be able to have a common platform to be able to compare that to education and highways and whatever, so that the government can make those decisions across all areas. And so, as Andrew mentioned, they have software in the SHA to kind of do this at that level as well. And so these, our ability to actually track maintenance priorities and deficiencies and that sort of thing is improving, and to actually manage them. So both at a provincial level and at an SHA level.
And so if that is carrying, and now if you're going to be dependent on another agency, i.e. SAS Builds, for that piece of the work here, I'm just kind of curious to know how that might impact on the progress. Now that you've got to sort of feed into another process, but operated by another agency, and how, if you've got, can you just maybe explain to me how how you'll be able to monitor progress?
Thanks. Good afternoon, everybody. Billy Jo Morissette, Assistant Deputy Minister with the Ministry of Health. So maybe just a couple of things. So I'll maybe let Andrew speak to the piece around the software that he's talking about, kind of that at that SHA level, some of the more detailed information that they're going to implement that will really assist them at that level. But when it comes to the role of SAS Builds, some of the conversations we've been having with SAS Builds is really exploring the options for what is an appropriate, asset management kind of approach. And like Max said, trying to find out if it does make sense to have a standard kind of approach across the public sector to allow for better information, in a more consistent manner for decision makers across. Having said that, any solution or any option that we'd explore where we would take a consistent approach wouldn't change, kind of the data ownership or the responsibility or the roles of the various agencies. So the SHA would continue to maintain, they would be the keeper. It's their data. They would be expected to kind of input the key data into that system, and certainly would be using that information to, I think, supplement what they might have in their own systems to help them make decisions as well. So it really doesn't, I don't think, would affect the ability of this work to progress. I think it can complement it. And just with respect to the VFA, we continue to maintain that system. So until we have sorted out the appropriate option to move forward, we'll continue to maintain that in a way until we have that, so that we do, continue to have good information available to us to make those higher level funding decisions at that ministry level.
Thank you for that further explanation. Next, on page 193, it states that as of November 2018, facilities management had not identified categories of critical assets, and ventilation systems were used as an example. Can you provide any information on what type of ventilation systems are used, the status and the need, and what sort of improvements? I think ventilation systems obviously have become, a priority area with COVID, and just looking to understand how that's being approached.
So we, in Saskatoon, as a follow-up to these recommendations, they did do an assessment of all of our critical building service components, and they have sort of applied a risk assessment, to those components, and we are using that to make decisions about where we're making investments in terms of improvements to those facilities. And actually, I'll use that example. I know through that process, for example, for Royal University Hospital, the OR exhaust system was one of the improvements that was made just knowing that kind of where it was in its life cycle and the impact on patients if that were to go down, it would disrupt surgery. So yeah, that would be my example, and I think we've progressed in that area to sort of more proactively make that assessment and then make investments where required.
On page 201, it states that not completing timely demand maintenance increases the risk that an asset may fail and cause harm to residents, patients, visitors, and staff. Just curious as to whether a critical incident has ever occurred due to a maintenance request not being completed in a timely manner.
Answer to that question. But if I could maybe just speak a little bit about demand maintenance.
Yep.
So demand maintenance is a little different than preventative maintenance. Preventative maintenance, you have a schedule and you're regularly doing service. Demand maintenance is more when something is broken, not working, and staff report that, and then the maintenance team follows up. And I'll just say in response to this recommendation, they have put in place a process to, well, I would say the smaller quick fix kinds of demand maintenance, they flow through real time. If it is something that requires a more significant time commitment on the part of maintenance to address the issue, they do have a risk matrix that they apply and then make a decision, which items that they address more urgently and others that could wait. So, I would just say that certainly, your question is, I guess just connecting the impact that can have on patients and the teams have put a good process in place to make sure we're getting to the most important things first when they do break. And, our goal is that we've got preventative maintenance to a level where those things are not breaking unexpectedly, but it does happen for sure.
I think in the first recommendation, you made mention that there was a high-level assessment of critical infrastructure, and that there were maintenance activities that had to be deferred. I think that was because of COVID. I'm not sure, but if you could maybe speak to what ended up having to be deferred.
Sorry, which recommendation is that related to?
Number one.
I believe number one was implemented.
Yes, and just when you were talking about the actions taken to implement since the provincial auditor's report, and you mentioned, I may have heard wrong, but I believe you had said that there were some deferred works, and I was just curious to know what those were.
So it sounds like that was completed, but not to the deadline that was expected.
Oh, okay, I see. All right, thank you for that. And then, sorry if I'm jumping around a little bit. Under recommendation number 5, so Health Authority use its planned maintenance activities as an input to setting its maintenance budget. You mentioned that this is partially completed and that you're developing a risk-based plan to maintain Saskatoon area facilities. So, yeah, just a little bit curious there to know, obviously, there is a need for setting some sort of priority and what the factors will be in doing so?
Thanks for that question. So I don't have the specific criteria with me, and we could sure provide that. But we basically, all of the sort of maintenance requests from across all of our facilities within the SHA do feed in, and we do score those according to objective criteria, and it would consider things like, impact to patient and resident safety, or impact to operational availability, or other criteria. It could consider the current condition or age of the element that's being requested, and then we prioritize those, and then those projects are ultimately approved, and then during the year the team implements those. And I should also mention that another improvement that has been put in place is a process for monitoring weekly the implementation of those approved projects, so that we complete those during the year, and we've made a significant improvement in terms of delivering those projects in a timely way. And that same process also is overseeing our demand maintenance. I should have made that comment when we were talking about that area as well.
Okay, thank you. Under recommendation number 8, you indicated that you're developing a reporting system to monitor completion rates and compliance to priority ratings, and you mentioned an escalation process as part of that one. Again, it's a similar kind of a question, just in terms of understanding what would, maybe you could explain the escalation process for me, and how it applies.
So, yeah, as I understand it, the teams are tracking their preventative maintenance log, and then as in the weekly monitoring that I described, they're looking at how long each of these different requests are outstanding.
And then if they sort of fall behind, then they get escalated. Is that the idea?
Yeah, and I think one of the points that I was wanting to make earlier is previously across the province, in some cases, maintenance staff would report to a general healthcare administrator at a site. And in other regions, they might have reported up to someone that had responsibilities for a maintenance program within the former region. The way we've designed our structure now is that all of the site facility managers that might have a team report up to an area director that's accountable for maintenance. So it's those area directors that are monitoring, the completion rates of the work, whether it be demand maintenance or the more significant facility improvements that are approved to be done during the year.
So what sort of things would contribute to a project needing to be escalated? Why would a project fall behind? Or not hypothetically, but in real terms.
That's a good question. So here, one of the challenges we have in healthcare is many of our spaces operate 24 hours a day, 365 days a year. So at times it's challenging to get in and do that work, because it means literally disrupting a service for a period of time. So certainly there are times when our clinical teams will maybe be facing a peak in healthcare demand and say, hey, it's not a good time to come in and do that work. So that might result in a delay to the work being done. But ultimately, an escalation might be required if the issue is not getting addressed. And I would say communication that needs to happen between the maintenance people and the clinical people in terms of when can the work be done. So that'd be a real example.
And is that something you're assessing in an ongoing manner to sort of understand what's causing escalations?
Yeah, well,
as a management function.
Yeah, so I think that's where I was describing like the area directors that have accountability for maintenance.
Okay.
They are having regular meetings with their teams to monitor the work. And I'll say in Saskatoon, for example, I know that they have like visibility walls, that where they're literally tracking like the issues of the day, and if something is breaking down, then the team will kind of redirect maybe change the plan for the day so that they could address that issue that's there. And so those conversations, for sure, it's part of our improvement process so that staff can say, hey, here's the challenges that I'm having, and they can problem solve and share ideas in terms of like how do we get into that space that we're having trouble getting into because it's too busy, and they can kind of work through that. And it might be that someone that's more senior may be helping to kind of problem solve that issue.
And then sort of final question on that, recognizing that this is sort of a partially implemented recommendation, I mean, I'm just kind of wondering about what happens, say, at the end of a year where you haven't quite met the targets for, planned maintenance, preventative maintenance. You've managed it all the way through your escalation process, what have you. But at that point, like, do you have a way of assessing and understanding the overall limitations and improvement opportunities?
I think the CMMS, or the Computerized Maintenance Management Program, is really going to help us have some good data in terms of how effectively are we completing our planned maintenance. And I think that will also support kind of resource allocation in terms of, do we need to reallocate some staffing resources from one part of the province to another to be able to meet the requirements of the facility. I also think as we populate the preventative maintenance requirements into the computerized maintenance management system, it will allow us to actually quantify like how much work is involved in completing that preventative maintenance, and I think that also will help us in terms of resource allocation decisions.
I guess I also recognize that because there has been an amalgamation and a transition is underway, and then you layer COVID on top of that, it's not like you're operating in normal times. But nevertheless, just in terms of how it's been going overall, is there a sense that, these annual maintenance plans have been sort of realistic in scope and being achieved?
Well, I appreciate your initial comments there, because these teams, like maintenance staff across the province, have really had to, go above and beyond to try and accommodate, some of the COVID requirements. And I'll use Saskatoon as an example. They literally expanded ICU capacity, and it was, all hands on deck to be able to do that work. So, the improvements that I've described, they've done these, in addition to responding to the demands placed on them through COVID. So yeah, that certainly is a real concern. Sorry, in the last part of your question again, I just lost my train of thought there.
Well, it was how realistic have you found the plans to be, and then looking back to see sort of like what's been.
So yeah, thank you for that. So in terms of the budgeted initiatives for facility improvements that we've done, we've as I mentioned, we really made some strides forward. We're delivering those projects now more effectively than we ever have. Part of our improvement there is we've now moved to a 2-year budgeting process that allows us to do planning, design, and procurement prior to the initiation of the next year once those dollars are approved. It also, by doing that, it also allows us to take better advantage of summer months for some of these projects that do have some weather sort of implications to them. The other change that we've put in place is the weekly monitoring that I mentioned of all of our projects. So we have project managers that are literally tracking all of the approved projects and ensuring that that we achieve those during the fiscal year, and it's definitely helped us deliver our projects in a more timely way.
Okay, no more questions.
Thanks for the questions. Thanks for all the work on these important fronts. Looking for any further questions? Not seeing any with respect to this chapter. I would welcome a motion to move that we concur and note compliance with recommendations 1 and 9. Mr. Gowdy moves. All agreed? That's carried. I would look for a motion that we concur and note progress with respect to recommendations 2, 3, 4, 5, 6, 7, and 8. Moved by Mr. Friesen. All agreed? That's carried also. Oh, we have recommendation number 10. We should include it. And that was, just make sure I've got, that was also one that was implemented. Sorry for not identifying it. I'd welcome a motion to concur and note compliance. Mr. Scoropad moves. All agreed? All right, that's carried. Okay, we'll move along to Chapter 24, and I'll turn it over to the Provincial Auditor.
Chapter 24 of our 2019 report, Volume 2, on pages 197 to 222, reports on the processes the Saskatchewan Health Authority uses to treat patients at risk of suicide in Northwest Saskatchewan. This chapter includes 8 new recommendations. The rate of suicide has been consistently higher in Northwest Saskatchewan than the rest of the province for the last 3 years. In 2018, the average suicide rate per 100,000 was 27.9 in Northwest Saskatchewan compared to the provincial average of 18.7. This higher rate increases the importance of the authority appropriately treating patients at risk of suicide in this part of the province. Healthcare services can offer a significant role in preventing suicide by screening for suicide risk and appropriately following up on positive screens. The public health system failing to assess suicide risk may result in missed opportunities to identify suicide-prone individuals and to provide timely treatment to help them address contributing factors. Not doing so may subsequently result in fatal consequences. We concluded that for the 12-month period ended August 31st, 2019, the Saskatchewan Health Authority had, other than the areas highlighted in our 8 recommendations, effective processes to treat patients at risk of suicide in the Northwest Integrated Service Area. In our first recommendation on page 207, we recommend the Saskatchewan Health Authority work with others, for example, the Ministry of Health, to analyze key data about rates and prevalence of suicide attempts to rationalize services made available to patients at risk of suicide. The Saskatchewan Health Authority has not sufficiently rationalized whether services available to patients at risk of suicide in Northwest Saskatchewan address the demand for services in this area. This, in part, because it does not have complete key data. Also, we found its analysis of existing key data was limited. To assess services provided to patients at risk of suicide, good practice suggests focusing on 4 key measures: suicide rate, hospitalization rate for self-injury, emergency department rate for self-inflicted injury, and prevalence of suicide attempts. We found complete data is largely available for some of these measures. Specifically, our analysis of data found Northwest Saskatchewan has higher rates of suicide and self-injury hospitalizations than the provincial rates. The authority and the ministry do not have any coordinated efforts to analyze data related to the services to patients at risk of suicide. We found funding for suicide prevention programs fragmented across provincial government agencies, the federal government, and First Nations agencies. Better coordination and analysis of multi-sector suicide prevention strategies may identify duplication or absence of services in certain communities. Systematic trend analysis of key measures by hospital and by geographical region would inform the planning and implementation of treatment programs. It would help the authority determine whether it gives individuals at risk of suicide in Northwest Saskatchewan sufficient access to services. Such analysis would help the health sector determine if its programs are making a difference. In our second recommendation on page 211, we recommend the Saskatchewan Health Authority give suitable training to staff located in Northwest Saskatchewan caring for patients at risk of suicide. The authority is not giving staff at facilities in Northwest Saskatchewan working with patients at risk of suicide with sufficient training on caring for these patients. We found the authority has not determined its training needs for staff in the area of caring for patients at risk of suicide. Rather, the authority allows staff at individual facilities to determine and coordinate their own training needs other than for staff training on new clinical-related IT systems. We also found the nature and extent of training vary significantly, and the training provided did not meet the foundational training expected in the Saskatchewan Suicide Framework. Training helps keep staff up to date. Not providing sufficient ongoing training for staff treating patients at risk of suicide increases the risk staff may not follow practices the authority expects and may provide patients with inconsistent care. In our third recommendation on page 214, we recommend the Saskatchewan Health Authority follow its established protocols to provide psychiatric consultations to patients accessing emergency departments in Northwest Saskatchewan who are at high risk of suicide. Staff and facilities located in Northwest Saskatchewan consistently followed established protocols to screen patients for risk of suicide, but emergency department staff did not always seek psychiatric consultation for patients with a high risk of suicide. We found the authority had clear protocols for handling patients who came to the emergency department and indicated a plan to attempt suicide. It expected healthcare providers to rate those patients who attempted suicide or had a plan to attempt as high risk. It also expected the staff completing the preliminary screening to consult with an emergency department physician to validate the assessed risk of suicide. Where an emergency physician agreed with a high level of risk, it expected the emergency department to consult with a psychiatrist for further assessment and determine next steps. We tested 23 files of patients who attempted suicide and came to emergency departments and found staff did not always follow the protocols to consult with a psychiatrist prior to discharge. We identified 3 instances where patients with intention of self-harm did not see a psychiatrist prior to their discharge. Emergency department healthcare providers not consistently following the authority's protocol to consult with psychiatrists prior to discharge of a patient with a plan to attempt suicide increases the risk of those patients not receiving needed support and treatment. In addition, it may open the authority to litigation if it did not provide the patient with appropriate care. In our fourth recommendation on page 215, we recommend the Saskatchewan Health Authority address barriers to using video conferencing to provide psychiatric services to communities in Northwest Saskatchewan. The authority has not analyzed why patients at greater than a low risk of suicide are not showing up for scheduled telehealth, that is, by video conferencing appointments. Its provision of psychiatric services through telehealth also remains low. We found the authority's use of telehealth for providing psychiatric services depends on whether it has a sufficient number of psychiatrists available. We also found patients poorly utilize telehealth to access psychiatric services in Northwest Saskatchewan. For example, in both 2017 and 2019, the rate of patient no-shows for telehealth appointments with North Battleford psychiatrists was at least 50%. The authority recognizes no-shows result in a significant amount of unproductive time for psychiatrists. Research shows psychiatric consultations and short-term follow-ups can be as effective when delivered via telehealth as when provided face-to-face. Given the geographic spread and size of communities in Northwest Saskatchewan, use of video conferencing can help patients and psychiatrists minimize travel time and cost to attend face-to-face appointments. Not determining reasons for poor use of video conferencing for psychiatric services in Northwest Saskatchewan communities reduces the authority's opportunities to identify and address barriers to its use. In our fifth recommendation on page 217, we recommend the Saskatchewan Health Authority analyze reasons patients at risk of suicide miss appointments for mental health outpatient services to help address barriers. The authority actively follows up with patients who received outpatient and inpatient services, but does not know why certain patients do not show up for scheduled appointments. We tested 22 patient files and found the authority followed its follow-up protocols for patients at risk of suicide receiving mental health inpatient and outpatient services. However, we found patients often miss appointments, which disrupts the continuity of clinical care. Not knowing why patients miss appointments reduces the authority's opportunities to identify and help patients overcome barriers to attending appointments. Such information would help the authority assess the appropriateness of its services for patients at risk of suicide. In our sixth recommendation on page 219, we recommend the Saskatchewan Health Authority follow up with patients who attempted suicide, discharged from emergency departments in Northwest Saskatchewan to encourage treatment where needed. In Northwest Saskatchewan, the authority's follow-up protocols for patients at risk of suicide accessing services through emergency departments differ from those for patients accessing services through mental health outpatient services. Research supports that contacting people and providing support after discharge from emergency departments reduces suicidal behaviors and deaths. For 4 files tested of patients who attempted suicide and were discharged from emergency departments, we did not find any evidence of the patient being referred to mental health or addiction services. Having differing follow-up protocols for patients who attempted suicide accessing health services through emergency departments from those accessing services through outpatient services may result in not providing patients with consistent levels of care. Proactive follow-up care promotes continuity of care and continues the assessment and management of suicide risk. In our 7th recommendation on page 220, we recommend the Saskatchewan Health Authority conduct risk-based file audits of patients at risk of suicide in Northwest Saskatchewan. The authority does not use a risk-based approach for conducting patient file audits in the Northwest Saskatchewan healthcare facilities. Patient file audits can determine whether staff follow policy and provide appropriate care to patients at risk of suicide. The Saskatchewan Suicide Framework expects former health regions to audit 10% of mental health inpatient and outpatient files monthly to determine whether files document the various items, for example, suicide screening, discharge plan. The authority did not conduct monthly mental health outpatient file audits since April 1st, 2018, or inpatient file audits since March 31st, 2019 in Northwest Saskatchewan healthcare facilities, as the framework expects. We also found the past inpatient and outpatient file audits conducted in Northwest Saskatchewan did not cover all of the framework's requirements. Conducting systematic risk-based audits of patient files would help supervisors of management actively monitor staff and help identify areas needed for improvement. Not following policy may result in inadequate services provided to patients at risk of suicide. In our 8th recommendation on page 221, we recommend the Saskatchewan Health Authority periodically inspect the safety of its facilities in Northwest Saskatchewan, providing services to patients at risk of suicide. The Saskatchewan Suicide Framework requires annual facility safety inspections of inpatient facilities to identify obstructions to staff, observation of high-risk patients, and physical structures that patients could use in attempting suicide. We found the authority does not formally inspect the safety of facilities periodically in Northwest Saskatchewan used to provide mental health, inpatient services, or emergency department services to patients at risk of suicide. Not doing periodic, robust inspections of facilities used to care for patients at risk of suicide increases the risk of not sufficiently identifying and addressing safety risks. I will now pause for the committee's consideration.
Thank you for the presentation. Thank you for the focus of the work as well. I know this impacts so many lives, not just in the region that you speak of, but so many across the province. I'll turn it over at this point to Deputy Minister Hendricks for response, and we'll open it up for questions.
Okay, recommendation number 1 on page 207. The SHA considers this recommendation implemented. Key data has been acquired and analyzed in collaboration with the Ministry of Health and Saskatchewan Coroner's Office. the data to rationalize the alignment of resources and provision of suicide prevention initiatives that are currently in place, or this data serves to rationalize, sorry. Analysis shows that the former Kiewit and Yauthe Health Region suicide rate is higher per capita than other areas of the greater Northwest area. Rates are highest amongst Indigenous males between the ages of 18 and 31, with the highest rates in the La Loche area. Although rates of suicide have seen a decline in the 2015 to 19 period compared with the 2010 to 14 period, prevalence in this geographic area continues to be higher than average compared to other Northwest areas. The SHA's objective is to continue to review and update data annually to ensure that resources are targeted to the areas of highest need. Resources have been realigned in La Loche, Buffalo Narrows, and Isle La Crosse. For recommendation number 2 on page 211, the SHA considers this recommendation partially implemented. The SHA has provided an up-to-date suicide risk assessment / intervention training for all new and existing mental health and addictions staff in the Northwest who were previously not trained. This skill training has been provided through the suicide response policies and or other related training such as applied suicide intervention skills training, critical incident stress training, violence threat risk assessment, and traumatic event systems. Ongoing work continues with the Ministry of Health and other partners to develop a full standardized menu of suicide risk assessment and intervention training options that will be tailored to meet the needs of all staff, both mental health and addictions, and those working in areas including primary health care, emergency rooms, community partners and agencies. A process for tracking the completion of required training is being developed and implemented. Recommendation number 3 on page 214, the SHA again considers this recommendation to be partially implemented. Excuse me, a process for referring from emergency departments to psychiatry for consultation for patients at high risk of suicide has been developed. An algorithm for emergency room physicians and clinicians for direct and immediate consultations to LINK, which is the provincial on-call consultation service for specialists, including psychiatry, or 24-hour on-call psychiatrists for patients at high risk of suicide, has been discussed and shared at some, but not all, Northwest sites to date. Recommendation number 4 on page 215. The SHA has not implemented this due to the pandemic. On recommendation number 5 on page 217, the SHA considers that this recommendation is partially implemented. Work standards have been developed that clinicians follow to track no-shows of clients deemed to be at risk for suicide. Mental health and addictions clinicians provide follow-up phone calls to all clients who do not show up for appointments in order to find out what are the reasons. What are the reasons, if any, for missed appointments, and discuss barriers they experience in regards to attending their scheduled appointments. Standardized processes to analyze reasons clients miss appointments are not fully developed yet. The former Kiewit and Yauthe Health Region is still in the process of fully implementing the mental health and addictions information system, so the proposed mechanism for research needed to analyze reasons for missed appointment services is delayed. Recommendation number 6 on page 219, the SHA considers this recommendation implemented. Each site in the Northwest Saskatchewan has now implemented a process to follow up with high-risk clients after they are discharged from the emergency department. The process and standards are designed to meet the needs of the respective communities. Recommendation number 7 on page 220, the SHA considers this recommendation to be partially implemented. Auditing procedures for remote and northern sites continue to require some fine-tuning. However, auditing of client files has been expanded to other sites in Northwest Saskatchewan as a mandatory process. The former Keewatin-Yawthey Health Region is in the process of fully implementing the Mental Health and Addictions Information System and will initiate file auditing and reporting with that implementation. Recommendation number 8 on page 221, this is not implemented. Primary healthcare executive directors in Northwest Saskatchewan plan to ensure annual safety inspections were completed and results were received in a timely manner beginning in March 2020. The implementation of this recommendation was delayed as a result of new safety protocols limiting access to facilities during the pandemic. Consultation, on-site meetings, and site visits will occur as soon as reasonably possible. In the meantime, managers and staff of inpatient units, particularly inpatient mental health units where patients with higher suicidal risks are admitted, would regularly monitor their units for safety risks. And that's all she wrote.
Thank you for the presentation. Thanks to folks that are involved in life-saving efforts and work on this front. I'm going to turn it over to committee members for questions. Ms. Ritchie.
Thank you, Mr. Chair. And I want to first of all start off by thanking the provincial auditor and her staff for the important work you have been undertaking to highlight deficiencies within the delivery of services for suicide prevention. And I just want to acknowledge the importance of that work, the vital nature of that work, ensuring that we're addressing what is an unacceptably high level and rate of suicide in this province, and in particular in the northwest part of the province. So again, I want to thank you all and your team very much for that work. Next, Deputy Minister Hendricks. Thank you for your status report, and in particular your response on the first item, where you've provided some updated information on that need for analyzing key data and the results that you've found from that work. I think that's very important. The auditor has stated in 2018 the average rate per 100,000 of being significantly higher than the provincial average, so 27.9 per 100,000 compared to the 18.7 provincial average. I'm wondering if we can be provided with updated numbers for 2019, 2020, and 21.
Good afternoon. So the 2019 data in the suicide rates per 100,000 residents was reported in the auditor's report. For 2019, the numbers, updated numbers for the provincial rate are 17.6, and in the former Prairie North RHA 23.77, and the former Keewatin RHA 31.9. The numbers for 2020 and 2021, we don't have those resolved yet, so the coroner's data is typically a little bit lagged. Takes a little bit of time for those to be confirmed, but as Max mentioned in his statements, certainly as the information comes available on an annual basis, we would continue to be looking at those rates.
All right, thank you very much. On page 210, It's noted that full-time psychiatrists in Northwest Saskatchewan as of 2018 are predominantly found in larger centers like North Battleford. I'm wondering if you can tell me if that is still the case, and I would also like a breakdown of the number of psychiatrists by location in Northwest Saskatchewan and if there are any vacancies currently.
Yeah, we can provide a list of the number of physicians in those communities. So in North Battleford, there are 5 full-time psychiatry positions, and then again we have 4. We contract with 4 psychiatrists on a fee-for-service basis to provide services in Lloydminster as well. But the next closest larger community where we'd have psychiatry is Saskatoon. What you, I think, would strive for in a lot of these northwestern communities is to have, other mental health workers and that sort of thing have strong connections with psychiatry in those larger communities as a referral service. But that's where we have that. Those are the numbers, and we can provide them as you need them historically.
Based on what I've been able to take in so far today, I get the impression that there's a heavy reliance on the video conferencing system to deliver psychiatric care in much of or all of the north, and there's been, I think, some also identified challenges with that approach, and in regards to the there was one recommendation around missed appointments at sort of a 50% success rate. I wonder if someone can help me find the number that refers to, Mr. Chair. Anyways, I guess what I'd like to know is if the service delivery mechanism or method is seen as succeeding, what is being done to address the deficiencies with it, increase the rates of attendance and address any other barriers, and maybe you could speak to what those barriers are.
I'll start, and then Andrew McCletchie, who's Northern Integrated Health, can join in. So one of the things that we had relied on for a lot of Northern specialist consultations is telehealth. I guess it works well in psychiatry, ideally, but the challenge with telehealth is it required the provider to have a suite, and oftentimes for the patients to move to a suite to actually receive the consultation. One big plus of the pandemic is I think we've come a long way on virtual care, where we've looked at using technologies that we wouldn't have thought maybe of using before, and we're continuing to expand those because we're realizing the value in that. So obviously telephone is the primary mechanism that was used during the pandemic, but we're looking at other technologies that are more basic that people can use on their phones and that sort of things that are secure and should provide increased opportunities for many Northern residents to access psychiatry and other specialized services without leaving their community or their house for that matter. I think this can go a long way in terms of mental health, but there has to be somebody on the other end of the line, and that's maybe probably the more challenging part is providing the access through either psychiatrists, but there are also a number of other mental health staff that are very qualified. It doesn't always have to be a psychiatrist. So maybe Andy, if I missed anything.
So as Max said, I'm Andy McClutchie, the Vice President of Integrated Northern Health for the Saskatchewan Health Authority. And Max is right that there is sort of challenges with accessing suites where telehealth exists. We also, in a sense, have challenges for a number of residents, particularly in the far north, being able to have a phone that has access to data, and so using some of the other tools to connect with professionals at a distance. I think the other thing to point out here is I do think there's a lot of in-person kind of visits. The psychiatry out of Saskatoon travels to places like La Loche and Isle of Cross, usually twice a month, to provide in-person services in those communities. And so the telehealth services are there to kind of provide follow-up support as well. The local mental health clinicians are often the ones who are following up and connecting clients in need with psychiatry.
So when you talk about some of those challenges with the client or patient being able to utilize the service through telehealth, I know we're short on time, but I am really curious to know if there is any work or effort being undertaken to improve access and address that reality.
Yeah, telehealth is maybe, I shouldn't say it that, like, it has been utilized in certain jurisdictions very successfully in Northern Ontario. They've had much better success with it than we have here in Saskatchewan. But, I think when we step back, for specialties like psychiatry, whether they really require a fully automated telehealth suite. And one of the biggest impediments, too, is with a telehealth suite was that the provider had to leave their office to go to the telehealth suite to connect to, which was as big a problem getting them to, because that takes time out of their day and that sort of thing. It's just that technology's advanced. We don't require that big setup to do this. We can carry images and allow consultations to be conducted through remotely without having to have all that equipment. And even in some other specialties that rely on more than just a discussion and face-to-face contact, there are other diagnostic instruments that can be plugged into your home computer, right, that allow people to monitor you remotely, or health professionals to monitor you remotely. So I think we're just seeing an evolution of the technology, and I think it is opening some opportunities for this.
Maybe just one more question then. You mentioned the location of psychiatrists in Lloyd and North Battleford, Saskatoon. Is there any effort underway to retain and recruit qualified mental health practitioners to be situated in communities in the northwest area of the province?
Yes, there's been a number of positions through some of the funding that the province has provided for mental health and addictions that have been created in northern Saskatchewan. Unfortunately, there's been challenges with recruitment and retention kind of to places like La Loche and Buffalo Narrows and Isle of Cross. But there's an ongoing effort to try and find people that want to work in those northern communities and to provide those services to the people there.
And can you describe what some of those challenges are and what's being done to address them?
I think there's a number of challenges that probably exist. Some of it is wanting to live and work in a northern remote community. Housing is often kind of brought up as a challenge in these locations. It's also kind of, I think, with some of the challenges with recruitment that we've seen in those communities, people are bringing up that not having consistent people that they're working with becomes a barrier to being able to provide as good a service as they'd like to, and it speaks to the need for ongoing retention of staff once we hire them.
And so in relation to that, so I guess what I'm asking then is also on the retention side, are there incentives, programs? How are you approaching that from a strategic angle?
In the far north, there is northern incentives that are built into most of the collective agreements, and those include both weekly kind of cost of living benefits as well as an annual retention bonus, if you will, that is given after each year of work there. And those are largely kind of the mechanisms by which we kind of support northern people or incentivize working in the north. There is also housing that's made available in a lot of our communities that, although the staff pay for it, it is subsidized to some degree.
And I think I was sort of lumping together psychiatrists and mental health professionals. So while I understand probably that the psychiatric teams do the sort of fly-in that you mentioned twice per week or per month. And I wonder apologies if you've mentioned this already, but what is the current level of vacancy rates in the north for mental health?
For mental health positions or for
Yes.
psychiatry?
Mental health.
Mental health. For you, I don't have that information.
Okay, I appreciate that. Thank you very much. No more questions, Mr. Chair.
Thanks for the questions, and thanks for the work. I just have a question with respect to, I guess it relates to recommendation number 6 about those people that have arrived at an emergency who have attempted suicide, and then to maybe broaden that category, those that are presenting at an emergency room who have suicidal ideation or are presenting serious risk of suicide, that they're expressing that. Is there follow-up, I guess, first of all, on the Northwest Saskatchewan, is there follow-up then with all of those patients or only those who have attempted suicide? Would that also include those that are showing up and stating that they're at risk of suicide and expressing suicidal ideation?
So each site in Northwest Saskatchewan has implemented a process to follow up on high-risk clients, not just those that have attempted, but I guess that would include people that have suicidal ideation. So anybody that's discharged from emergency, there's a process now and standards to follow up with them in their respective communities.
Well, I think that's really important, so thanks for the work that's been taken on to make that happen. I guess my question is, this pertains to Northwest Saskatchewan, and this is a matter of concern across the province. Is that standard practice now? Is that same follow-up occurring province-wide for anyone who's presenting to emergency rooms across Saskatchewan?
Yes, it's intended to be the standard across Saskatchewan, and I think part of the follow-up to these recommendations is to make sure that that's occurring across the province.
Thanks. It's a point of concern that at times there seems to be some gaps on that end, and I really appreciate the focus and the work on this front. So thank you for that. Any other questions from committee members with respect to this report? Mr. Friesen.
Yeah, I just had a quick question for the auditors. When you're talking about the telehealth versus in person, you're saying I just want to confirm that I heard it right, but pretty much an equal outcome, doesn't matter which way it was. Is that kind of where you were going with that?
Yeah, so what we did find is that research does seem to indicate, and yet I would say during the course of the audit, we did find that basically when a patient does, it's almost that initial meeting with a psychiatrist, like building that relationship. Being in person is obviously preferred and better. I think as the Deputy Minister indicated, I think things have evolved now with COVID, and patients and a lot of us are more acceptable of different types of technology mechanisms in which we are able to receive care. But yeah, research did indicate to some degree, you know, sort of talking and meeting in person or over video is the same. I guess it's much like us auditing now, right? Like if I'm talking to you through a camera or talking to you in person, hopefully it'll be relatively similar results.
Wow, that's really neat. Thanks for that.
Further questions at this point? Not seeing any right now. What I would, I'd welcome a motion to concur and note compliance with respect to recommendations 1 and 6. Moved by Mr. Nerline. All agreed? That's carried. I'd welcome a motion with respect to recommendations 2, 3, 5, and 8 that we concur and note progress. Mr. Gowdy, all agreed? That's carried. And with respect to recommendations 4 and 7, I'd welcome a motion that we concur. Mr. Friesen, all agreed? Agreed. Just a note to folks that might be following along here as well, that just a reminder of the thorough follow-up process as well that the auditor's office has. We hear the undertakings and the commitments that are being made and the actions that are being taken. The auditor then follows back up, reports out publicly to the people of Saskatchewan. That comes back to this table as well. What we'll do now is move along with our agenda and turn our attention to Chapter 39 of the 2019 report, Volume 2, and I'll turn it over to the Provincial Auditor.
Chapter 39 of our 2019 report, Volume 2, on pages 293 to 301, reports the results of our first follow-up audit of the former Cyprus Regional Health Authority's processes to deliver accessible and responsive ambulance services. By April 2019, the Ministry of Health and the Saskatchewan Health Authority had implemented one of the 7 recommendations we made in our 2016 audit. The authority implemented a process to confirm ambulance operators, either owned or contracted, hold a current ambulance license. All ambulance operators in the former Cyprus Health Region held current licenses at April 2019. While the ministry did not analyze whether it needs to change the Ambulance Act, it worked with the authority to develop a performance-based contract template for contracted ambulance service providers. The new performance-based contract template clearly sets out service quality expectations, for example, response time targets, and requires regular reporting on specific measures, for example, the volume and quality of services provided. As of April 2019, the authority continued to work to implement new contracts with private ambulance operators using the template over the next 2 to 3 years. Through the new performance-based contracts, the ministry and the authority should obtain better performance information to use in conducting a future comprehensive review of patient demand relative to ambulance services across the province. Also, collecting better performance information, like delayed response times, should also support the authority in assessing the success of its ground ambulance services and determining actions to take when ambulance are not responding to service calls within the targeted 30 minutes in rural locations. I will now pause for the committee's consideration.
Thank you very much for the focus of this work. And thank you to the ministry and folks that have been involved in implementation on these fronts. There's a lot of work that's occurred. We've got a status update here. I know with respect to these recommendations, they've come to this committee already. We've concurred in them, and we have the report out here today that demonstrates implementation. So I think our scrutiny can be a little more expeditious at this table. I would maybe kick it over to the Deputy Minister to see if he has some brief remarks with respect to this chapter, and then I'd open it up for committee members.
Thank you. So maybe I would just go through the status of the recommendations fairly quickly. So on page 295, which is the first recommendation, the SHA considers this partially implemented. So the SHA Emergency Medical Service Portfolio has developed a proposal to stabilize rural and remote ambulance services. This has come forward to government for budgetary consideration and will be part of our annual budget cycle. Number two, the SHA, on page 296, the SHA considers partially implemented. All contracted services in the Southwest except one have been converted to new performance-based contracts. The remaining performance-based contracts are expected to be executed by the end of 2022. The auditor's third recommendation on page 297, the ministry considers this recommendation implemented. The ministry has conducted broad EMS sector consultations in 2017, and at the conclusion of the consultation process, consideration was given to legislative amendments. It was determined that the focus for enhancing contract management practices would be through the introduction of a standardized performance-based contract. As mentioned in last, the contract will also support greater consistency across EMS services and improve quality of service. Number 4 on page 298, we also consider this implemented. I think the auditor agrees with us on that one. On number 5 and 6 on page 298, the SHA considers these recommendations implemented. They're monitoring progress on monitoring response times against targets, with monthly and quarterly reports being provided to the Southwest Manager of EMS and the Director of EMS South. The reports include the reasons specific calls did not meet response times. Recommendation 7, the SHA considers, on page 300, sorry, the SHA considers partially implemented. Reporting against performance metrics is expected to be implemented with the new computer-aided dispatch system planned to begin in October 2022.
Thank you for the report out, and I may have misspoke just with respect to one of the recommendations. That was the one that you just identified, recommendation 7, where you've laid out the timeline that's coming around to full implementation. I'll open it up if there's questions from any committee members. I do want to say thanks for, providing the report on all the actions and implementation, because it allows us to cut to the chase at this table. Not seeing any again. Ms. Deputy Chair Young.
Are there currently any open contracts that you're working on and using this new template with? And if so, what concerns or challenges that have come forward with the new template?
Thank you for the question. Corey Miller, Vice President of Provincial Programs for the Saskatchewan Health Authority. We've worked with the operators in developing that performance-based agreement. So there was a collective group of SHA leadership, ministry leadership, and members of the Professional Association of Paramedics and owners of, so we worked with them in developing what was a fair and reasonable performance-based agreement. As Deputy Minister Hendricks mentioned, we haven't got everybody to sign them yet. I would say we have a few, but it is targeted by the end of 22 for that to happen. I wouldn't say there's lots of challenges with it. Just some operators like the Ambulance Act and the accountabilities and performance measures that they do and don't have to report in it. But I'd say we're getting there, and it is an expectation that they sign that or we won't be renewing their agreements. So specifically, there's a requirement for them to report response times, and I would highlight we're being reasonable in it. We are a large geographic province, and with the response times for emergencies being 9 minutes and 59 seconds, it's not possible for some services to reach an accident in that time frame. So we are being reasonable with them and asking them to report the distances between their base and there, and we time them on that 9 minutes and 59 seconds from that distance. So in this area, I'll give you the example, the provider in Pontex responding to Cadillac, that's a 15-minute drive. The expectations are they report anytime it's more than 15 minutes and 9 minutes and 59 seconds to that site. That allows us to measure their performance at a standardized way. Some people don't like the fact that they're going to have to report those types of variances in their performances.
And the Ambulance Act itself has different numbers in it.
Yeah, we haven't.
Assuming that they're.
We've always had response times. It's the reporting of the response times.
So it's the reporting part. It's not what's the standards that are there. Okay, thank you.
Good questions. Thanks for the responses. Not seeing any other questions at this time, I'd welcome a motion to conclude consideration of Chapter 39, moved by Deputy Chair Young. All agreed? That's carried. Moving right along, I'm going to turn it over to the Provincial Auditor to focus on Chapter 35 of the 2019 report, Volume 1.
Chapter 35 of our 2019 report, Volume 1, on pages 323 to 327, report the results of our second follow-up on recommendations we first made in 2014 about Prince Albert Parkland Regional Health Authority's processes to provide timely and appropriate home care services in the City of Prince Albert and surrounding area. By February 2019, the Saskatchewan Health Authority had implemented the 3 remaining recommendations. The authority improved its compliance with established policies and procedures for completing required needs assessments, for example, an in-home safety assessment, and began conducting monthly audits to monitor compliance with its needs assessment policy. Tracking compliance rates helps the authority monitor the work done. Completing each of the required needs assessments help ensure clients receive all the required home care services and reduce the risk of injury to clients and staff. The authority also formed a home care approval committee for Prince Albert Home Care to review and approve all clients' home care plans. We found staff work schedules aligned with approved home care plans. Consistent review and approval of home care plans confirms the appropriateness of assessed needs for home care services. Having schedules that align with approved home care plans helps ensure clients receive the services based on their assessed needs. I will now pause for the committee's consideration.
Thank you for the report, the focus of the work. I'll turn it over to the Deputy Minister, and we'll go from there.
All of the recommendations, I believe, are implemented, so no further comments from the Ministry or the SHA on this item.
Ms. Ritchie, you have about 10 or 15 questions on the matter. Thank you to the Ministry for the work, and looking to committee members for questions.
Thank you, Mr. Chair. Thank you to both the Provincial Auditor for that report and the Deputy Minister for the current status and completion of the audits. I do have some questions. Can you tell us the number of clients or patients that are served within this this area?
Unfortunately, we don't have that with us right now. We can provide that to the committee through the chairs.
Okay, thank you. I was also interesting to know, for comparison purposes, also what the provincial-wide numbers would be.
That as well.
Okay. Also, the number of nursing visits for the past number of years. I guess this audit was in 2019, and so just wanting to know the number, both that as well as home support services, and in order to get an idea on the trends, and if you had any comments on that.
So the question was on the trends for home support?
Number of nursing visits and home support visits.
I don't have those numbers on me right now.
Okay. So it's also nice that, and good to learn that the Home Care Approval Committee for the Prince Albert Care Home, I'm just wondering if there's any is this specific to the Prince Albert area, or are there similar kinds of committees operating in other parts of the province? Is this a standard practice?
The answer to that is there are committees, and they're sort of being pulled under each area within the province. So there would be 6 different committees within each of the 6 areas that would be looking at that service provision.
Just one follow-up question. I would just like a little bit more information on the membership on those committees and the kinds of matters that they're considering.
So those committees here.
Hi there. I'm Karen Earnshaw, the Vice President of Integrated Rural Health with the Saskatchewan Health Authority. The home care committees would be made up of various classifications of licensed providers, primarily nursing, so registered nurses and registered psychiatric nurses, but there also would be representation representing therapies, predominantly occupational health therapy and physiotherapy. And then there also would be representation of social work. So essentially the scope and the range of services that would be provided to home care clients would be represented on that committee.
And the other part of that question was the scope of their agendas, the matters that they're discussing, and I guess the mandate for the committees, if you could sort of speak to that.
Well, the mandate for those committees has really shifted to provincial standardization. The committees would have been mandated by their former regions to ensure consistency and application of care protocols across a former region. But really the work of those committees now that would sit under the new 6 integrated health areas would be really to focus on standardization provincially. I will tell you that the committees have been less focused on home care throughout the past 20 plus months, simply because those primary health care committees in general have been very focused on things like prevention, immunization, et cetera. But that is the work of those committees to look at. Our care is access, so access to home care. Is that standardized? And then is the delivery of the care standardized provincially?
And so I'm wondering how patient concerns might come to that committee, like what sort of input do patients or their representatives have any input?
They do, but it would be through the same advocacy. The patient, each former region has got access to here, and bring forward patient concerns, which would be no different than if that concern was raising out of long-term care or an acute care or any other community-based program.
I see. Thank you for that. No further questions, Mr. Chair.
Good questions. Any further questions? Not seeing any. Thanks for the work on this front. I'll welcome a motion to conclude consideration of Chapter 35. Mr. Scoropad moves. All agreed? That's carried. We'll move along, and I believe Chapters 40 and 33 are going to be, they're related. One's the follow-up. They're going to be dealt with together. I'll turn it over to the provincial auditor.
Chapter 40 of our 2019 report, Volume 2, on pages 303 to 308, and Chapter 33 of our 2021 report, Volume 2, on pages 241 to 245, report the results of 2 follow-ups on our 2017 audit about processes to deliver provincially funded childhood immunizations in La Ronge and surrounding area. By July 2021, the authority strengthened its processes to deliver provincially funded childhood immunizations in La Ronge and surrounding area by implementing each of the 5 recommendations we first made in 2017. We note that this follow-up audit did not include processes around delivering the COVID-19 vaccine. While within La Ronge and surrounding area, we found the authority annually analyzes and reports on childhood immunization coverage rates by community and properly stores vaccines as required by the Saskatchewan Immunization Manual. The authority properly managed and protected its vaccine inventory by regularly reconciling its on-hand inventory to quantities recorded in its records and completing emergency event recovery plans. In addition, it provided periodic reports to senior management on coverage rate information as it related to provincially funded childhood immunizations to help determine whether immunization services are effective, that is, providing the right level of services in the right locations. I will now pause for the committee's consideration.
Thank you very much for the presentation, the focus of the work. Thanks to the ministry for their work and for reporting out their efforts on this front. I'll kick it over to the Deputy Minister for brief comments and then open it up to the committee.
Like last chapter, all of the recommendations have been implemented, so we have no further comments.
Thank you very much for the implementation, the efforts on this front. It's certainly a real important area of work that impacts so many people's lives. Any questions from committee members with respect to these 2 chapters? Ms. Ritchie?
Yes, thank you. I think as it relates to Chapter 33, we see that regional versus provincial childhood coverage rates on page 245, that there is a lower than average rate of immunization for 2-year-olds for pertussis and measles. What is SHA doing to increase those rates?
We're doing a number of things. Predominantly, there's work because this area includes both a lot of Indigenous communities with services delivered by those First Nations as well as ours. There's work happening between the Northern Population Health Unit and the Northern Intertribal Health Authority to basically kind of look at what are the causal agents kind of behind people or children not getting immunized. When they identify different communities with lower rates, they often kind of come up with strategies working with local leaders to look and see how they can increase the uptake. They also will shift resources within kind of the Northeast area, 1 and 2, to meet the needs of the various communities to do sort of immunization pushes and that to improve access for individuals who might not otherwise have good access.
Maybe as a follow-up to that, and appreciating also that these recommendations have been implemented, can you speak to that more sort of in a systematic fashion? Like, are there ranking and tracking and management oversight?
Yeah, so basically on a monthly basis, there's a review of immunizations that are due, as well as, like, 'cause every month, new children that would hit the 2-year mark would, in a sense, be eligible that weren't previously. And so the team kind of reviews both who are the children that are coming on that require immunization and how well have we done in the past month on immunizations that have occurred in that previous month. And based on that, the public health teams come up with strategies to try and continue to increase the number of vaccines that occur.
And one final question. Has La Ronge an area the SHA dealt with staff absenteeism or shortages in the last year? And if so, expand on the impact, if any, on service delivery?
Yes, there's been shortages of staff in the La Ronge area, and in some ways impacted both by pressures with the pandemic, where in a sense they've required more staff, particularly in the public health area, to help with vaccination for COVID. And the process by which they've sort of looked to say how do they meet the needs of the population as a whole, still they tried to remain very consistent with that process and looking to say what's needed in the next month or weeks ahead in order to meet the needs of the broader population as it relates to immunization or other public health concerns.
That's all the questions I have for now, Mr. Chair. Thank you.
Okay. Thank you. Thank you for the questions. Any further questions? Not seeing any. Again, reminder to anyone following along that we've had these recommendations fully considered at this table and scrutinized, and now we've had the report out on the actions that have, caused implementation to respond to these recommendations. I'd welcome a motion to conclude consideration of chapters 40 and 33 respectively. Moved by Deputy Chair Young. All agreed? That's moved. We'll move along now to Chapter 41, and I'll turn it over to the Provincial Auditor.
Chapter 41 of our 2019 report, Volume 2, on pages 309 to 312, reports the results of our second follow-up of the Saskatchewan Health Authority's actions on 3 remaining recommendations we first made in 2015 about processes for the safe and timely discharge of hospital patients from its 2 acute care facilities in Regina, Pasqua Hospital and Regina General Hospital. The authority implemented 1 recommendation and partially implemented the other 2 recommendations. By June 2019, the authority's 2 acute care facilities followed its policy of documenting its patient discharge instructions and discussing those instructions with patients before discharge. However, those 2 facilities often did not follow the authority's policy to conduct medication reconciliations before discharging patients. Only 2 of 30 patient files we tested contained completed medication reconciliation. These reconciliations help to reduce drug-related incidents. As of June 2019, the authority was in the process of automating medication reconciliations. We also found those 2 facilities inconsistently documented consultations with healthcare providers in a central and comprehensive manner to facilitate a coordinated, informed approach to individual patient care. In our testing of 30 patient files, we found 27 files that required consultations with other healthcare providers, but did not incorporate the results of documented consultations in the nursing care plan. Rather, the patient files only noted that the consultations occurred. Consistently documenting consultations between healthcare providers in one central location, for example, nursing care plans, provides complete information to help healthcare professionals make informed decisions about a patient's care while in hospital and promotes a coordinated approach to patient care. I will now pause for the committee's consideration.
Thank you very much for the follow-up and the report. I'll turn it over to the Deputy Minister and then open it up for questions.
So the first recommendation on page 310, the SHA has partially implemented that recommendation. The SHA Regina area is in the process of implementing the accountable care unit model of care at the Regina General Hospital. Next steps include formalizing physician commitment to participate in daily multidisciplinary rounds at the patient's bedside, resulting in patients and families being part of and understanding the daily care plan. The remaining two recommendations on page 311, the second recommendation on page 311, the SHA considers implemented. Medication reconciliation has been implemented on all medical and surgical inpatient units in Regina. Processes are consistent with Accreditation Canada requirements. And then the third recommendation on page 312, I think the auditor acknowledges is implemented.
Thank you very much for the presentation, for all the work. I'll open it up if there's any questions. Ms. Ritchie.
Thank you, Mr. Chair. So as it relates to the first outstanding recommendation and the accountable care unit model of care, it's mentioned that there's still the need to formalize physician commitment to participate in this daily multidisciplinary rounds at patients' bedside. And I apologize, I know probably this has been discussed at previous committee meetings, but just kind of given sort of the status of where that's at, what's needed to sort of move that to completion? Or what might be getting in the way of moving that to completion?
The Vice President of Integrated Urban Health and the Chief Nursing Officer in the Saskatchewan Health Authority. The model of care that's described is an integrated team-based model of care. So in order to have the physicians present on the unit, we have set up teams of physicians, and they're rostered and contracted. So there's been work underway over the last couple of years to finalize the contracts to support the physicians to be engaged in the units with the teams. So that's the work that's been underway, and has taken us a bit longer to implement at the General Hospital with COVID, as the physicians were engaged in COVID care versus moving forward with the model of care.
So are you suggesting that, or is it the case that it's a contractual negotiation issue that is needing to be resolved?
Change, so there's work with the physicians and the integrated team to finalize the model and then ensure that the contracts are integrated with and align with the model. So it's a two-part process.
I see. Okay. You have December of this year as the deadline or date for completion. All things considered, how is that anticipated to be completed within that time, or what? Okay. All right. I did have a few other quick questions I wanted to ask on a few other points. So on page 311, I'm just looking for an update on the move to electronic health records. The auditor had noted in June 2019 that the SHA had not decided when it would make this move. So I'm just wondering where that's currently at.
So the SHA independently can't move to an electronic health record, so we work with our partners at the Ministry and eHealth to support rolling out of an electronic health record within the health system and across the health system.
So there is a budget proposal that has been submitted by the SHA. The move to an electronic health record in our acute care facilities is a massive IT project from both, I guess, a complexity and a cost perspective, and so it will undergo the budget review process, and we'll see where it ends up.
Well, okay, I think I'm going to just leave that there. That sounds like it could be a fairly long discussion. Maybe we'll get some follow-up at a later point. As it relates to the expansion of, no, I think I'll scratch that one. Just in terms of the pandemic, what changes, if any, have staff made to ensure patients are discharged in a safe and timely manner?
Sure, safe and timely discharge wouldn't change due to the pandemic. So what you've seen described as the work is the same work. So our teams continue to communicate with families, do team-based rounds where patients and families are there, and ensure that they're aware of the discharge plan and have written communication to follow up. So the recommendations that you see here, that work continues, and it would be, we would apply those same processes to safe, timely discharge during COVID as we would if we didn't have COVID.
Right. So in the current state, with hospital capacity, can you tell us what current capacity levels are at the Regina hospitals?
Regina hospitals, today we get daily reports. They are at a reasonable capacity. They had a small number of individuals waiting for beds this morning that I was aware of. So the hospitals are full. We continue to transition patients onto units, care for them, and transition them to other areas of care on an ongoing basis.
And when you say the hospitals are full, I think I've heard numbers reported by percentages and sometimes even over 100%. And can you tell us what that percentage would be today?
If I could get my phone, I can tell you the report from this morning. Is that?
Thank you.
Might take me a minute to find the. Noon today, we talk about the geographically protected beds, which would be most of our medical and surgical beds. The Regina General Hospital was at 87% occupancy, and the Pasco Hospital was at 102% occupancy.
Thank you very much. No further questions, Mr. Chair.
Thanks for the follow-up questions as well. Any further questions? Not seeing any, I would welcome a motion to conclude consideration of Chapter 41. Moved by Mr. Gowdy. All agreed? That's carried. We'll move along to Chapter 24, and I'll turn it over to the Provincial Auditor.
Chapter 24 of our 2020 report, Volume 1, on pages 245 to 246, report the results of our follow-up of the Saskatchewan Health Authority's actions on the last outstanding recommendation from our 2013 audit about processes used to manage and administer medications in the Weyburn General Hospital and St. Joseph Hospital in Estevan. The authority implemented our last recommendation. As of November 2019, we found the authority consistently records and reviews patient medication profiles before administering medication to patients within its Weyburn and Estevan hospitals. A medication profile includes a patient's name, gender, age, known allergies, and a comprehensive list of medications taken in the past. This supports giving each hospital patient the right medication at the right dosage. I will now pause for the committee's consideration.
Thank you for the follow-up and the presentation. I'll turn it over to Deputy Minister Hendricks and then open it up for questions.
Nothing to add. This recommendation has been implemented as noted by the Provincial Auditor.
Thanks for the work and thanks for reporting that out. Questions? Ms. Ritchie.
No, my apologies, no questions.
Bit of a hair trigger on the questions, but I can understand how you kind of get into habit with these, and very good questions through the day. Not seeing any other questions at this point, I would welcome a motion to conclude considerations, or conclude consideration of Chapter 24. Mr. Friesen, all agreed? That is carried, and I'll turn it over to the provincial auditor to focus in on Chapter 25 of the 2020 report, Volume 1.
Chapter 25 of our 2020 report, Volume 1, on pages 247 to 255, reports the results of our first follow-up of the Saskatchewan Health Authority's actions on 7 recommendations we made in 2017 about the efficient use of magnetic resonance imaging, MRI, services in Regina. By January 2020, we found the authority implemented 3 recommendations and made progress on the other 4 recommendations. We found the authority developed work standards to have staff track the actual completion dates of each stage of MRI services and reasons for rescheduling MRI appointments in its IT system. The authority also implemented an audit process to validate the accuracy of data in that system. We found the authority began to regularly analyze MRI volume data on a weekly and monthly basis to identify significant patient waits for MRI services, but more work remains. Consistent with previous years, the authority did not meet demand for MRI scans in 2019 in Regina, which resulted in patients waiting more days than the MRI guidelines suggest. For example, there were 143 patients waiting more than 3 months for an MRI scan at December 31st, 2019. The authority needs to analyze the dates of the different stages of MRI services that it now tracks to determine causes and ways to address significant delays. The authority did not yet formally assess the quality of MRI interpretations radiologists provide. However, we found authority began working with eHealth to develop an IT system to help assess the quality of radiologist interpretations of MRI scans. It plans to use this system to have formal peer reviews of the scans performed. While we found the authority appropriately monitored the selection and volume of MRI scans sent to contracted licensed private operators, it had not yet developed a process to monitor the timeliness and quality of MRI scans performed by these operators. The authority requires private operators to follow the wait time guidelines for public MRI scans. Under the one-for-one model, a private operator is to schedule a second scan within 14 days after completing the privately paid scan. We tested 10 scans provided by private operators and found 3 scans where a private operator took longer than the 14-day requirement. Lack of timely MRI scans performed at private operators may indicate a concern with their prioritization methods or capacity. This impacts how long patients are waiting for MRI services. Once the authority implements processes to assess the timeliness and quality of all MRI scans, it needs to determine the nature and timing of additional information senior management and the board will need to receive to better monitor MRI service delivery. Having timely and quality MRI service delivery alleviates patient stress, avoids unnecessary referrals, and reduces costs. It also facilitates timely and appropriate diagnosis or treatment to help improve patient outcomes. I'll now pause for the committee's considerations.
Thank you for the work, the follow-up, and the presentation. I'll open it up to the Deputy Minister for comments and then to the committee.
Okay, thank you. First of all, I believe Mr. Miller has a clarification on something earlier. Mr. Chair?
Yes, Mr. Chair, I'd just like to address to the committee on Chapter 39, the ground ambulance service. The example that I used the wrong number, so my apologies, ma'am. On the rural response for emergencies is not 9 minutes and 59 seconds, it's 29 minutes and 59 seconds. So my apologies. I don't think it changes the difference would still be plus the 15 minutes to drive that distance, but I just wanted to make sure that that clarification was given. My apologies.
Thanks. Thanks so much for correcting that information, and I'll open it up to Deputy Minister. Do you have some comments at this time? Yeah.
Just a couple. So the provincial auditor has acknowledged that recommendations 1 and 2 on page 249 are implemented. The third recommendation on page 250, the SHA views this as implemented. The robust weekly reporting of MRI services is provided to operational leaders on a weekly basis to allow real-time changes to be made to address concerns. This reporting includes analysis of the nature and causes of the wait times and is being continually reviewed and enhanced via an iterative evaluation process. And then reporting for senior leaders is provided on a monthly basis using reporting created by the Ministry of Health in collaboration with the SHA. Recommendation number 4 on page 252, the SHA views this as partially implemented. The SHA and radiologists are developing a peer learning program that will be dependent on technology updates to the provincial information system. Although this initiative is a priority for the SHA, the implementation of peer and learning review systems has been delayed. The target has been delayed from the targeted and is now targeted for implementation on March 31st, 2023. The fifth recommendation on page 252, the auditor has acknowledged is implemented. The sixth recommendation on page 254, the SHA believes is partially implemented. Monthly analysis report on MRI services, including contracted private services, are provided to operational and senior leaders. The report is continually being reviewed and enhanced through an iterative evaluation process, and the enhancements will be implemented, and this recommendation are expected to be in place by the end of 2022. The seventh recommendation on page 254, the SHA believes is implemented. Monthly and weekly analysis reports on MRI services are provided to senior leadership. Since SHA's amalgamation in 2017, reporting of these types of reports are submitted to senior management rather than to the board. That concludes my remarks.
Okay. Thank you for the work. Thank you for the presentation. And I'll open it up now to the committee for questions. Ms. Ritchie.
Thank you, Mr. Chair. So I've got a few questions here on some of the partially implemented recommendations, and I just note that the peer learning program is awaiting or is dependent on some technology updates to the system. I presume that's through eHealth. Okay, yeah. And is this, yeah, maybe you could just help me understand what the delay, or what are the things that are sort of going to affect that moving forward?
Corey Miller, Vice President of Provincial Programs again. The peer learning is a way in which the radiologist will reread something that's already been read by one of their peers, and it would be a percentage of the total number that are done. It will require some software changes to our PACS as well as our RIS system. So that will require IT support. I would stress, because I think this is an important point, that oversight and quality, there is a process through the College of Physicians and Surgeons of Saskatchewan, through what we call the ACMI committee, which is the Advisory Committee on Medical Imaging, where they do grant the license for private clinics, but they also do review of the radiologist quality of work. But would agree fully with the auditor's recommendation that the more we can do quality rechecks of peers, et cetera, in a professional manner, that's how we build a culture of quality where people can review each other's and have a process to give feedback to a peer. That's what we're looking to promote, but I will give you assurances there are oversights of quality through the College of Physicians and Surgeons of Saskatchewan. This will be supernumerary to that.
Okay, and I appreciate that further context. Just sort of drilling down, though, a little bit here, what is the nature of the technology updates that need to be performed?
So what it'll do, it will create a work list for the re-review. So the peer review system, our radiologists read, whether it be an MRI, X-ray, CT, on a workstation, and they have a work list that they read through. A peer review would be a separate work list that somebody is assigned today that will be a reread of a percentage, whatever the department and us decide is the percentage that should be reread on a peer percent or from a peer perspective. So it'll be the creation of a work list in the PAC system and in our radiology information system so that we can track and report the percentages of the peer review. So that's what we're looking to build into the software of both the radiology information system as well as the picture archive communication system.
So you're saying that there isn't an app for that presently?
We would want to build it into the existing workflow that the radiologists do. So some of them might be scheduled this morning in CT or in MR or in ultrasound. There would be a peer review period where they would take their turn each in the schedule where they would be doing peer review.
Okay, that was actually a poor attempt at a joke. But
I got it.
Okay, thank you. Couple other quick rapid fires here. What is the current wait list to access MRIs in Saskatchewan, and the average number of people on the wait list for previous years going back to 2018?
Mark, you can.
Hi, Mark Wyatt, Assistant Deputy Minister. So in Regina, right now, the average wait list based on data up to December 2021 for a patient who received an MRI was 77 days. If you were to look at sort of the 90th percentile, which is another way that we will often measure, 90% of patients received their MRIs in Regina within 188 days. Right now, Regina is comparable in terms of the number of patients waiting for an MRI at 4,980, which is just slightly above Saskatoon. But of interest, the number of patients who are waiting greater than 90 days is significantly lower at 1,917, which is about 700 below where Saskatoon is at. So we are seeing wait time numbers, performance in terms of the number of patients waiting over certain periods of time actually in a better position in Regina than what we would see in Saskatoon right now.
How many private operators of MRI services are there in Saskatchewan?
You would have
There's four.
four, okay.
There's 4 clinics. There's 4 clinics, 3 providers.
Private clinics? And versus?
Publicly administered, privately delivered. So we give them the patients funded from through contracts.
Okay, thank you. And what is that compared to the number of public clinics?
So we in Saskatoon, there are 4 MRIs in the hospitals, one at St. Paul's, one at City, 2 at RUH. There's one at the Moose Jaw Hospital, and there's 2 at the General Hospital in Regina.
Oh, okay. I greatly appreciated timely access to those services when my daughter fell and bumped her head on the playground when she was small, and it can be very scary. And there's a whole range of reasons people, I understand, use MRIs, but I know I certainly appreciated having that timely access. That was many years ago now, but these questions are making me think of that. Also, So can you expand on how the pandemic has impacted delivery of MRIs in Saskatchewan?
For sure. I mean, it touches a little bit on what you questioned us this morning, and one of the comments that you made where people haven't accessed healthcare in the way that they should have, or because people were at home and not accessing primary care and their family physician the way they would have. So we actually saw a reduction in the amount of referrals for many of our imaging modalities. I'm quite proud to say I think our imaging facilities within our healthcare did a great job of continuing to move and do urgent and semi-urgent patients. We did see reductions. There was the process of doing imaging throughout COVID was impacted with socially distancing, right? We've leaned our processes. We have waiting rooms, which we now had to separate patients. But I would say all in all, the healthcare system certainly saw a reduction in our referrals in and a small reduction in our throughputs of our imaging. But I will say, you know, as COVID has drawn out and patients have been going to their specialists, we've certainly seen a larger increase over the last 6 months of referrals for specialty imaging tests. For sure, we've seen an increase.
If I could maybe just add one thing to that. When it comes to wait times, it was interesting because you saw the reduction in the number of new referrals coming in, and particularly elective referrals during that first sort of 3-4 months in the spring of 2020. The wait times actually dramatically dropped in terms of how quickly people were getting their MRIs, because you were dealing primarily with higher urgency cases. And then as the services ramped up, what you then saw was the wait times increasing because people who had been waiting for whatever amount of time, plus with no or very few elective cases going through during that spring of 2020, then you saw the wait times that people were, the time that they had waited to get their MRI jumping pretty significantly. And then since then, we have in both, by virtue, as Corey said, in restoring service levels, but also investing in an in-year investment that was provided last year to increase the number of CTs and MRIs in both public and private facilities has also helped to really stabilize the wait times, and that sort of takes us to where we are today.
Well, that's okay. Well, that's good to know. And maybe just one follow-up on that. If you could sort of speak to sort of like the systems that are in place to sort of help with the prioritization and managing those service loads.
That's similar to the laboratory examples that we gave this morning. We receive requisitions from referring clinicians from all over the province, which have a prioritization referral. They're also reviewed by our radiologists and prioritized. So they're reviewed by the clinical team and then placed into the urgency level 1, 2, 3, 4. And a level 1 is emergent. There really isn't a wait. It's the next available time we can get them reasonably onto one of the tables. So that's how the prioritization process works.
Okay, thank you for that. Finally, so in the status update that SHA will regularly monitor private MRI operators as of December 31st. Can you expand on kind of what this will look like, what the plan will actually be?
Can you repeat it? I'm not sure I follow your question.
Yeah, I may have done a poor job of asking it. So section 3.5. And if you can, just there's 254.
I can just explain to you as the leader of provincial programs, includes medical imaging on monthly basis, we review it with the leadership team of imaging, so the executive director and directors of imaging from around the province. We go through our wait times, which includes the services now that are being contracted out to the private facilities. So that's part of that review that they provide to us. But I will say they're continually reviewing those data and making adjustments. And I think it's important to understand, we hear about our MRI wait times every day. We have daily huddles with our teams, and it's almost on a daily basis that we hear about the inpatient pressures for MRI, and that's why our outpatient partners are so important in the delivery of this. It's not uncommon for us to have, we have a computer monitor, we call it the whiteboard, but it's really an electronic monitor that's monitoring the amount of inpatients that are awaiting imaging, and that's reported on a daily basis to myself and Dr. Babin as the leaders and responsible for those, because it's important. Those patients are waiting for testing, which might be allowing them to be discharged or allowing a disposition for further care as needed. So, but the private facilities, the work that they do with us and for us is reported to us on just like it is with our own facilities now, because they're important partners of ours.
Okay, thank you for that. No further questions, Mr. Chair.
Important questions, and thanks for all the work on this front. These services are so critical to folks. I see Deputy Chair Young has a question.
Is there a certain percentage every year of out-of-province referrals to MRI? And if so, what would that percentage be?
Well, that's a good question. I can't think of a whole lot of procedures that we would refer out of province anymore. I think
Coming in is what more like?
I mean, on the Alberta side, certainly we get spillover from the Lloydminster and adjacent area. But I mean, we have people traveling through our province who require emergency care all the time, and that's for certain. We certainly get lots of referrals in from Flin Flon, from that Hanson Lake Highway way, but I wouldn't we see a huge amount of out-of-province referrals in for services within our buildings. It's not a major complement.
Further questions on this chapter? I would welcome a motion to conclude consideration of chapter, just make sure, chapter 25. Looking for a hand or a nod. Oh, Mr. Gowdy, boy, he's quick there. That's moved. All agreed? All right, that's carried. We'll move along now to chapter 26.
Chapter 26 of our 2020 report, Volume 1, on pages 257 to 258, reports the results of our fourth follow-up of the Saskatchewan Health Authority's actions on the last remaining recommendation from our 2010 audit about processes to maintain medical equipment within healthcare facilities in Melfort and surrounding area. The authority implemented our last recommendation. By November 2019, we found the authority maintained medical equipment within healthcare facilities located in Melfort and surrounding area within reasonable timeframes and in accordance with manufacturer's requirements. In addition, future maintenance schedules set out in its IT maintenance system aligned with manufacturer's maintenance requirements. This decreases the risk of equipment not working properly or safely. I will now pause for the committee's consideration.
Thanks for the presentation. Thanks for the update. I'll flip it over to officials if they care to offer brief comment, and we'll go from there.
Thank you. As this one is implemented, no further comments from the ministry. Thank you.
What a great report. I'll open it up to the table for questions. Not seeing any there either. I think the MLA from Melfort's trying to take credit over here, but not seeing any questions. I'd welcome a motion to conclude consideration of Chapter 26. Moved by the member from Melfort, Mr. Todd Gowdy. And all agreed? Okay, that's carried. We'll move along to Chapter 27. There's a bit more to this presentation.
Chapter 27 of our 2020 report, Volume 1, on pages 259 to 262, reports the results of our second follow-up of the Saskatchewan Health Authority's actions on 7 remaining recommendations from our 2014 audit of processes related to medication management in long-term facilities located in Kinnersley and surrounding area. By December 2019, the authority improved several processes for managing medication plans for long-term care residents in facilities located in Kinnersley and surrounding area. We found it implemented 5 of the 7 remaining recommendations we made in 2014. The authority improved documentation in its residents' files by including quarterly medication reviews, prescription changes, and nurses' notes. This documentation decreases the risk of patients receiving incorrect medications, dosages, and frequency. The authority also established processes to identify trends and issues related to medication management. It summarizes medication incident reports centrally for facility managers to identify trends in medication incidents and create targeted training to correct the incidents. For example, the authority identified fentanyl patch incidents where extra patches were found on residents, and as a result, delivered training to staff. In addition, the authority initiated a process to assess the appropriateness of antipsychotic prescriptions given to residents. The authority still needs to document informed consent from long-term care residents or their designated decision makers for the use of medication as a restraint or when changes to high-risk medications are made. We found 47% of the 17 resident files tested where medication was used as a restraint did not have informed consent on the file, while 31% of the 13 resident files tested with changes to high-risk medications did not have documentation to support that decision makers or residents were informed. Decision makers or residents should be aware if medication is used as a restraint or is changed, as medication can significantly impact a resident's quality of life. I'll now pause for the committee's consideration.
Thank you for the focus in this work, and then all the follow-up as well, and of course all the actions that are reported out towards implementation here. Looking for any comments from officials, and we'll open it up.
Thank you. We'll do a quick status update on this one. So for the first 3 recommendations found on page 260, as noted by the auditor, these recommendations have been implemented. The SHA does utilize a multidisciplinary team approach to complete quarterly reviews of medications of residents in long-term care facilities located in Kindersley and surrounding area. Resident files include information on quarterly medication reviews, medication administration records, prescription changes, and, as noted by the auditor, notes from the nurses. With respect to the 4th recommendation found on page 261, the SHA considers this recommendation implemented. A new education program was rolled out in 2020 to all registered nurses and licensed practical nurses for the least restraint and consent for high-risk medication policies. With respect to the 5th recommendation found on page 261, the SHA considers this recommendation implemented as well. Staff are following a policy that was created that requires informed written consent from long-term care residents or their designated decision makers for changes in high-risk medication. For recommendation number 6, the provincial auditor has noted this recommendation has been implemented, so no further comments there. Similarly, for recommendation number 7, no further comments on that one. Thank you.
Thanks again to all that have been involved in this this very important work and to bringing about this change. I'd open it up for questions, if there are any. Ms. Ritchie.
Thank you. Thank you. It's, I'm just taking a moment to catch up here. So just for clarification, maybe to start with, so the status of recommendations in the report on page 261 indicates that the 2 recommendations related to, obtaining informed written consent not being implemented, but are you indicating that it has indeed been now? Yes? Yes. Okay, great. Just wanted to make sure I'd heard correctly on that point. So In that case, I have no further questions. Thank you.
Thank you for the questions and the clarifications. Any further questions from folks with respect to Chapter 27? Not seeing any. I'd welcome a motion to conclude consideration. Deputy Chair Young moves. All agreed? Agreed. All right, that's carried. We'll move along now to Chapter 28 of the 2020 Report Volume 1, and I'll kick it over to the Provincial Auditor.
Chapter 28 of our 2020 Report, Volume 1, on pages 263 to 267, reports the results of our first follow-up of Saskatchewan Health Authority's actions on 5 recommendations we made in 2017 about processes to minimize employee absenteeism in Kinnersley and surrounding area. By November 2019, we found the authority implemented 1 recommendation. It implemented checklists for managers in Kinnersley and surrounding area to use in meetings with employees who have excessive absenteeism. However, additional work remains on the other 4 recommendations. We found the authority is in the early stages of expanding the role of human resources staff in promoting employee attendance. Involving human resources personnel is a way to reduce the workload for managers responsible for managing staff attendance. Human resources personnel can provide more timely absenteeism management, particularly when a large number of employees have excessive absenteeism. Authority management indicated it planned to implement a new electronic case management system in 2020-21 to better support attendance management. However, we note the capacity of human resources personnel must be reasonable to provide necessary support. We also found managers in healthcare facilities in Kinnersley and surrounding area are not consistently documenting meetings with employees who have excessive absenteeism. For each of the 7 employees with excessive absenteeism tested, we found the related manager did not complete a meeting checklist or alternate form of documentation to document discussions with or actions taken to address the absence. Finally, we found the authority's analysis and reporting on employee absenteeism remained virtually unchanged from our original 2017 audit. The authority's manual system in place does not collect sufficient data to complete adequate analysis. It has not yet gathered more information or performed analysis to enable periodic reports of its actions and progress on addressing the causes of employee absenteeism. Collecting necessary data and analyzing causes of absences would assist in the development and reporting of strategies to reduce employee absenteeism. Effectively managing absenteeism contributes to quality service delivery to the public, minimizes costs, and supports the well-being of employees. And I will now pause for the committee's consideration.
Thanks so much for the report and the follow-up, and we've welcomed some new officials to the room. I'll just a reminder for all new officials or those that haven't been to the table, when you come, just state your name before you speak. I'll flip it over to the DM for brief remarks, and then we'll open it up.
So recommendation number 1 on page 264, this is partially implemented. The SHA considers this recommendation partially implemented. Beginning in April 2018, the Ability Management Coordinator within the Human Resources was providing monthly reports on employees whose sick time exceeds the regional average to managers for review and follow-up. This functionality will be embedded in the administrative information management system development phase 2. Given there is not a timeline established for phase 2 implementation, the SHA will begin this analysis manually. This work has been paused throughout the pandemic to focus on accommodations work and redeploying staff to meet operational needs. Recommendation number 2 on page 265, as the auditor noted, this has been implemented. Recommendation number 3 on page 266 is the partially implemented. Beginning December 2017, managers are expected to provide copies of the formal meeting guides to the Ability Management Coordinator as evidence of the meetings. The coordinator was reviewing the completed guides and provides coaching to managers as required. However, this was paused due to COVID-19. Recommendation number 4 on page 266. The SHA considers this recommendation partially implemented. This will be addressed as part of the Administrative Information Management System development, where attendance support is planned for phase 2 of the project. The SHA will update processes to improve documentation of decisions to place an employee in an attendance support program or not, as well as documentation showing the types of supports offered and follow-up expected in an action plan for the employee. COVID-19 shifted SHA priorities in much of the AIMS project, as well as the majority of attendance support has remained paused during the past 6 months in order to shift resources to the COVID-19 response. As a result, there will be no meaningful progress on this recommendation. Work will resume once AIMS is implemented. This functionality will be embedded in AIMS in development in phase 2. Given that there is not a timeline established for phase 2, the SHA will undertake this manually. Recommendation number 5 on page 267. This is partially implemented again. The attendance management module of the new administrative management system will greatly improve the SHA's ability to report on attendance metrics, and reporting framework will be developed as part of the process. Work to implement this recommendation was delayed due to COVID-19 and will resume once AIMS is implemented. We expect to be able to produce the report for the board once phase 1 of the AIMS is implemented. That concludes my remarks.
Thanks for the report and all of the work on this front. I'll open it up to the committee for questions. Ms. Ritchie.
Thank you, Mr. Chair. So, yeah, I appreciate that the pandemic has gotten in the way of moving forward with the auditor's recommendations. And of course, you know, the capacity issues around healthcare workers throughout the pandemic is also duly noted. Certainly, it's been a tremendously challenging time, and other kind of, I guess, pressures on the system as they relate to the issues around sick leave. So just wanted to kind of note that situation. But I guess, you know, it does also speak to some longstanding healthcare staffing issues prior to the pandemic. And maybe just a starting point, if you could provide a current status update in terms of the situation as it relates to absenteeisms and whatever those, I think I heard mention of some sort of maybe a threshold for when some sort of remediation is needed and where things are standing in relation to those targets right at the current time.
Kyle Matthews, Executive Director of Organizational Development and Employee Wellness with the Saskatchewan Health Authority. In terms of sick time throughout the pandemic, I'll just quickly go through the last few years. 2019-20, we averaged 84.1 hours per FTE, 19-20, 84.33, and in 2021, the first year of the pandemic, 63.95, and as of 21-22 quarter 3, we're at 55.58. So over the course of the pandemic, we've actually seen a decrease in sick time amongst healthcare workers. Probably a number of different factors at play there. With the reduction in surgeries in the healthcare system, we wouldn't have people leaving for surgeries like we would normally have. Likely the increase of PPE amongst healthcare workers probably played a factor here as well. And then just the remarkable dedication of our healthcare staff to be at work throughout the pandemic, supporting the citizens of Saskatchewan.
In terms of the causes of the absenteeism, you know, going back to, the time of the audit and forward to now, can you just speak to how that issue is understood? Have you been able to do any sort of data analysis? I know that was recommended as part of the recommendations, but generally want to just kind of hear your view on what the nature of the issue is.
I think like we've responded in the report, we're still operating with 12 different systems capturing that data. And so to have any sort of a roll-up of that information, our plan is to wait for AIMS to be in place, or we need to wait for AIMS to be in place to have a consistent case management approach that would give us that data. So I don't have an answer for you currently.
But surely you must have some sense of from what you're hearing from managers and staff.
Yeah, so I think prior to the pandemic, obviously our sick leave numbers are concerning in terms of our ability to manage the system. So there are a variety of factors. Obviously, as healthcare workers, you're in an environment that exposes you to various things. And so naturally, there's probably a higher tendency for illness and also, the healthcare environment isn't without its stresses either. And so obviously sometimes, a healthcare worker, there will be other issues, some of it will be WCB related. Some will be related to, I just think, over time, so, obviously there are issues around workload and that sort of thing. But then, there are employees, I think, as there are in any sector, who treat sick time differently, and don't use it only for sick time, and so those are the ones that I think need to probably be managed, and I think the system will help us to more effectively manage those situations. I wouldn't say that they're the regular ones, but certainly there are those cases. I don't know, would that would
all be accurate, yeah.
In terms of the added stress of working through the pandemic, it seems like perhaps it's kind of gone the other way, where perhaps people have had need for a stress day or a day off, but haven't been able to take it. And because obviously it sounds like those numbers have come down quite a bit, so it seems like you've kind of got it at the opposite issue maybe on the table now. Just wonder if you want to sort of speak to that.
I would say for better or for worse, those numbers have come down, and again, I think that I think there's a lot of factors at play there. One of them, of course, is that our healthcare workers are exceptionally dedicated throughout the COVID pandemic. That said, I think I'm concerned for our employees post-pandemic and the mental health needs that we'll be facing at that time. We've been doing a lot of work to support our employees throughout the pandemic, supporting our leaders to better support their staff. But this is an area of concern for us in our organization for sure, and healthcare organizations across the country as well. So while it's good to see the dip in sick time, I don't think that's indicative of there not being concerns related to mental health amongst our staff.
And so, well, given that sort of changing situation, then how is management responding and preparing for that eventuality?
Well, there's probably been a few blessings related to COVID, but this has been one area where we've been able to put more effort, or not more effort, but more focus. There's been more of a pronounced need for this. So we're doing a lot of work with our management team across the board, helping them to understand the mental health needs of their staff. We're doing a lot of promotion of the
various supports that staff have access to, whether that's through our Employee Family Assistance Program, some of the other supports that we have available that they can access as they need to, as well as their benefits program. Recently, we've begun providing mental health supports on site for staff, and that was in response to a lower uptake of the as requested kinds of supports that we had available. And our thinking there was to eliminate any barriers to access that they might be having, perceived or real. And so in many of our major locations with ERs and ICUs, we've been having mental health supports available on site multiple days a week for our staff to take advantage of.
Great. I want to acknowledge the fact that, you've been operating through a crisis, and so under normal circumstances, there'd be a different capacity to monitor, adapt, adjust. With the current situation, you've kind of had to work under quite a bit of duress, and I appreciate, the adjustments you've been making on the fly here through, the on-site supports and so forth that you've mentioned. But kind of putting my auditor hat on, and just wondering, it's not really my job, but I do kind of do try my best in an unofficial capacity. Do want to ask a question, in terms of, what kinds of management processes are you using to kind of have that ongoing monitoring and tracking and adjustment sort of to meet those employee needs? It's kind of flipped from absenteeism to something else, but I think it's bears the question.
I appreciate the way you phrased that. I think it's an extension of the same for many of our staff members who have excessive absenteeism, that we treat them as whole people, and there's invariably mental health related issues at play when people are away from work and excessively. So your question was, sorry, I lost sight of your question there.
Sure. I was putting my auditor hat on. Yeah. And so the question was more about, sort of the system approach and the management reporting, the governance piece.
So the SHA, earlier this week, actually, Andrew and a few of his senior leaders and my ADM sat down and went over their Q4 priorities for this year, but also their priorities going into next year. And I think as a ministry and as a DM, I was pleased to see one of their number one priorities was basically the health of their staff. And so they have a number of initiatives that are training managers, some interactively through online things, but to recognize stress and mental health amongst their employees and even amongst themselves. And then going forward, during the pandemic, as Kyle mentioned, there were, initiatives where we did go into the workplace to provide support to workers who might be experiencing stress in the workplace. But we recognize that that's not going to end right away, and that, many of the after effects of the pandemic will linger for months, in some cases probably years. And so we're also going into another busy period too here, where we have a health system who's been through one stress test, and we're putting it back out there again because we have huge wait lists that have evolved during the pandemic, and so and pent up services. So we need to focus heavily, and we're working with the SHA on this because they're taking care of the folks that we've got. But also one of the challenges through the pandemic has been that, and it's a pan-Canadian, it's actually an international problem, is our whole HHR capacity. And so we're looking at strategies to bring additional workers in, to recruit more people. Nobody likes to work short-shifted, and there were certain areas that put extreme pressure on people. And so in certain professions. And so I think it's part of a comprehensive strategy that we're focused on with the SHA to try and alleviate some of this pressure coming out of this pandemic. Like I said, looking after the workforce that's there and who's done amazing work, but also bringing in the cavalry, to help them out over the next several months.
Thank you for that. Yeah, because I am part of my concern or question here is around, the things that might get in the way of responding to these changing needs, and sort of recognizing you're sort of on the other end of the spectrum with the issues facing healthcare workers. Is there anything further to add in terms of what might get in the way of addressing the needs and changing dynamic?
I don't think that, I think our biggest challenge obviously will be, in the near term, these solutions won't happen overnight that will immediately address the pressures on our workforce. And so we need to be mindful of that, and we need to, and Andrew can maybe speak more to this, or Kyle, we need to have strategies in place to maintain the health of our workforce and not to push them too far. But at the on the recruitment and retention front, we can do some things that are immediate, but to be blunt, these will take some time to address some of these issues, because we're competing nationally and internationally, as I mentioned, and some of it's around, do we have enough training capacity, that sort of thing, in certain programs, and so there's a fairly long lead time to educate some health professionals, and so we can look at international recruitment and who we have here who might be able to be trained up to provide certain services, or I think people, there are people out there that have, I guess, educational qualifications from other jurisdictions, that sort of thing that we can look at. But I think some of the reality is that this is going to take some time to fully address.
I can appreciate that. I guess what I'm hearing is, attract and retain in a highly competitive environment coming out of a pandemic. So appreciate that insight. No further questions.
Any further questions from folks around the table? Certainly a real thoughtful exchange. I just want to say I really appreciate some of the remarks I'm hearing from leadership around the recognition of the whole person and the sacrifice and pressure and mental health and wellness of the legions of healthcare workers and professionals across this province. I think making sure that that's supported is really going to be critical moving forward. So I just really appreciated sort of the language and the culture that I heard from leadership here today. So I'll look for not seeing any questions. I'll look for a motion to conclude consideration of Chapter 28. Deputy Chair Young, all agreed? That's carried. We'll move along to Chapter 29, and I'll turn it over to our provincial auditor.
Chapter 29 of our 2020 report, Volume 1, on pages 269 to 276, report the results of our first follow-up of the Saskatchewan Health Authority's actions on recommendations we made in 2017 about overseeing contracted special care homes in Saskatoon and surrounding area. By November 2019, we found the authority implemented one of the 6 recommendations we made in 2017. The authority, along with the Ministry of Health and contracted private operators of special care homes, clarified accountability relationships between all 3 parties. We found the authority started working with private operators to develop a new template contract. the authority planned to finalize the template by March 31st, 2020, and start work on signing new contracts with the 16 special care homes in Saskatoon and surrounding area. It expected new contracts may be signed over several years as current contracts expire. The authority clearly expects homes to provide quality care and follow the ministry's program guidelines for special care homes. However, it had not redefined performance measures or service expectations on which it expects special care homes to follow. It also was not yet inspecting special care homes' compliance with the program guidelines. At November 2019, the authority was waiting for the Ministry of Health to complete its revision to the program guidelines before it takes additional steps to improve its oversight of contracted special care homes. Necessary steps include defining the quality of services the authority expects homes to provide, assessing each home's compliance with those expectations and the ministry's guidelines, and addressing identified non-compliance to mitigate risks to residents within homes. At the time of our follow-up, contracted homes in Saskatoon and surrounding area continue to have performance issues. For example, 10 of the 16 contracted homes in Saskatoon and surrounding area had more residents than expected fall within the last 30 days. Not having a process to assess whether contracted homes provide quality care and take timely actions when necessary puts the residents of contracted special care homes at risk of not receiving quality services. I'll now pause for the committee's consideration.
Thanks so much for this, very important focus and the report here today. I'll open it up to Deputy Minister Hendricks, and then we'll get at the questioning.
Recommendation number 1 on page 271, as the auditor noted, is implemented. Recommendation number 2 on page 271, the SHA believes is partially implemented. Work continues on a principles and services agreement between the SHA and the Provincial Affiliates Resource Group. Excuse me, the body of the principles and services agreement and the quality and performance schedule are in the final review phase, and so the shared services schedule and funding and services schedule are in development. Progress on this initiative has been delayed due to COVID, but work is expected to be complete in the summer of 2022. On recommendation number 3 on page 273, the SHA considers this implemented. The Ministry of Health led a provincial review and revision of the program guidelines for special care homes. The ministry has developed an inspection process and will lead inspections of special care homes to assess compliance with guidelines. The inspections will report on the performance of each home's compliance to the guidelines. Corrective action plans to address any deficiencies will be reported and tracked by the ministry. The 4th recommendation on page 273, the SHA considers this partially implemented. The steering committee overseeing the overseeing the development of the principles and services agreement formed the quality and performance working group to establish minimum service expectations for high quality resident centered care. Key performance measures and targets that define service expectations related to the quality of care will be included in the principles and services agreement schedules. Work again was delayed because of COVID, but will be complete in the summer of 2022. Recommendation number 5 on page 274, the SHA considers this recommendation implemented. The Ministry of Health began inspecting long-term care homes in December 2021. Inspections assess the home's compliance with the province's program guidelines for special care homes and any related regulations and policies, focusing mainly on resident care and resident-centered work within the home. Routine inspections will occur on a 3-year cycle and may occur more frequently should programs be identified or problems be identified. And then recommendation number 6 on page 274. The recommendation has not been implemented. A framework, as I noted, for addressing non-compliance with agreed-upon key measures will be included in the new principle and services agreement. which is expected to be completed in the summer of 2022.
Thank you, Deputy Minister. I'll open the floor to questions from committee members now. Ms. Ritchie?
Thank you, Madam Chair. Yes, very honored to enter in here and with a few questions on a topic that concerns our province's most vulnerable and their care within the special care home systems in the province. So I guess as it relates to some of the partially implemented, you mentioned that you're in the process of finalizing an agreement with the care providers. Sorry, I'm just trying to find my place here. Yes, so you're working with the affiliate resource group, which I assume means the organization representing care homes, private service delivery?
It's an organization
Okay.
that represents all affiliate groups in the province.
Okay, good. Yeah, and so maybe if you could just elucidate for the committee what some of those outstanding items are. I think you might have referred to one in the last recommendation, but just like to understand sort of what's getting in the way of crossing all the T's and dotting the I's.
Sure. Sharon Garrett, VP Integrated Urban Health in the SHA. So the template agreement is with affiliated organizations and or designated healthcare organizations. Special care homes some are operated by the SHA and some are operated by affiliates. So these recommendations relate to the homes operated by affiliates. And with those organizations, we have worked with them in the past. The Provincial Affiliate Resource Group, PARG for short, represents the affiliates, and we are negotiating with them to finalize a template agreement, and then each individual affiliate signs their own agreement with the SHA. So it's a bit similar to the ambulance discussion you heard earlier, except that the agreement is actually the template agreement's actually negotiated with that group. So we've been at the table, we've been disrupted. As you've noted, the residents of long-term care facilities have been the most vulnerable to the impact from COVID. So a lot of our time has been devoted to ensuring that the residents are safe, adequately protected, and that we're also balancing policies so that they have a life balance. So there's been various points over the last 2 years where both the affiliates and the SHA have been busy with that work and not been able to sit down together to finalize the negotiation of the agreement. So the body of the agreement so originally the template referred to regional health authorities and other things that once the SHA came into formation needed to be changed. So there's certain items in that agreement that we're working through and as I said, are paused right now, but have a small list of items that we're working on with them that we'll be going back to the table with them as soon as we're able to finalize the body. And then, as noted here, there's schedules that define other parts of the agreement.
Okay. Now, I wanted to ask a question about, I would assume that if, negotiations are on these template agreements are kind of sort of where the rubber might be hitting the road would be around things like service levels. And would that be fair to say?
Quite honestly, the language in the body of the agreement speaks to our relationship. So the body of the agreement is about how we work together. It's not specific to the service level, because the service level and the funding provided is actually negotiated individually with each home. What we're doing in the negotiation with PARG is to find a way to describe those things in a way that's transparent and easily understood in the agreement. So, we haven't, that would be how I would describe it.
And then you mentioned schedule, so what sorts of, is this all part of the template, the schedules, and if you could give me a sense of the items that they'll cover?
So the schedules that are described in here, one describes the services that they're expected to provide. One describes the funding that they will receive in response to the services. One describes what's called shared services, and I would describe that as things that we will provide for affiliates, such as HR supports, LR supports, or payroll or scheduling. So there's been various supports that previous regional health authorities provided to affiliated homes in the past, and we're looking at what those services are. So those are described in a schedule. There's a schedule about the quality and performance. So there are quality indicators that are already measured, and those are measures that are reported up to CIHI, and they're nationally developed measures that look at quality of care in long-term care homes. So that there's a foundation that we're already measuring, but we're reviewing that as part of the process.
And then, okay, so this sounds like a bit of a two-step process. It sounds like it's a lot of work on the front end with these template agreements, but then once you have that, then you have to move into negotiating with each individual service provider. So as it relates to item 2 and working with the group, I think maybe you could just clarify for me if, those individual discussions with individual providers is also part of this time frame and the scope of the recommendation.
I think, as the auditor reported, we would be signing agreement once we agree that we have a body that we've agreed to. The signing with individual care homes would follow from there, and it would take a period of time depending on when they've been.
Yeah, so my question's sort of a timing question, because it's indicated here that you're going to have these standard agreements by July 1st, and I'm just wondering when the ones with individual service providers would be occurring.
Would follow after that, so
Okay.
we'd have to have the individuals' conversations following that.
Okay, great. Thank you very much on that front. I think I've got one more question here. Yeah, so on the number, number 5 is indicated as implemented. I'm just kind of wondering, though, with routine inspections, are there recommendations that will be part of that process? And then, are those binding, or how, when issues are identified, how are they going to be ensured that they're resolved?
Thanks for the question. So certainly, we are in the pilot stage still of this new inspection program, and certainly the intention would be, as there are findings, we would share those with the home. And as we would normally do in our system, when we see, when we have evidence from other things like quality indicators or other things that we're measuring, we would work with the home to produce a continuous improvement program. So we would like to see, plans in place to address the issues that are uncovered during the inspection process. And so that would be, depending on the nature of the home and who's operating the home. So certainly for the SHA-operated homes, we would have that, discussion with them. As it relates to affiliates and other third-party related homes, we'd have the discussion, of course, with the SHA and the third-party operated home, as those agreements are between the SHA and that third party. So certainly an intention is to share those learnings and work with the homes to improve the conditions that we uncover.
Are you saying that that is part of this pilot, though, that there will be recommendations flowing from them. I mean, you talk about working with, but I think we've seen quite recently from other reports by the Ombudsman in particular, where we've had, I'm not sure they were called recommendations, maybe they called them something else, but, there wasn't the follow through. So my question is, how do we ensure, regardless of what we call it or the process that we're using, how are we ensuring timely resolution of issues as they are identified, and we don't risk them falling through the cracks?
So maybe just to be a little bit more specific on the process, the home will receive a written report within 30 days of the visit. And so in that report, it will outline, issues that have been uncovered or expected plans that we'd like to see. And so certainly there will be a monitoring function that will come along with that, where we will continue to, much like we would do with other kinds of inspections, public health inspections and whatnot, we would do the appropriate follow-up to make sure that those actions are being taken and that we are tracking the progress of those in terms of, safety and quality of care.
Okay. That's all I have for now. Thank you very much.
Deputy Chair Young.
On page 275 of your report, you provided a chart that spoke to particularly Saskatoon surrounding area special care homes not meeting performance targets, and it was during that 2019. Has there been an updated one? I assume, even though you say they've been focusing more on ensuring that residents of our care homes currently during COVID have been paid special attention and they've changed their programming. But I'm assuming they still have to provide accountability reports, and if this chart has changed based on some of the performance standards not meeting targets in some of these homes, and some of them are significant as to what they were lacking.
So when we look to update this particular chart, there's some challenges in terms of, there was a change in the system, so we had some challenges pulling it at the time of this report. But what happens with each one of these, if they're not meeting a target, the homes are actually develop a corrective action plan, and then there's follow-up with the home again within 3 months about what the progress is. So there is ongoing feedback. There's actually ongoing feedback and review and looking at them. But I recall as we worked through this that, so I don't know if I have the updated data at this point in time in terms of that. The other thing that we've been doing in response to the pandemic is regular safety review with our infection control and safety teams going into the homes to audit all of the measures that we put in place around COVID. And each one of those reviews would produce a report and follow up, and our team would engage, and if needed, would actually help the homes meet the requirements around the measures that were put in place due to COVID. So we've done a couple of additional things, but there was a challenge, as I said. So I don't know that I have an updated chart, but it is a regular expectation.
You assure me that this has improved based on what I'm seeing here on the 7 different categories, and some were significantly higher.
That I can say that in response to that. So I wouldn't want to say that without the data in front of me. What I can tell you is that this is viewed as a quality improvement process, and some of these measures impact each other. So there's looking at residents in daily restraints. So we have a goal to not restrain residents in long-term care. If you don't restrain residents, there's some residents that will increase their risk of falls because of that. And then you need to have other measures in place in response to that. There's things like very low beds, padding and other things. So the measures are, sometimes you improve on one and then something else gets worse in response. So they're not always, they kind of flex as you pay attention to one, something else changes.
Thank you.
Important questions. Thanks for the responses. Any further questions, folks? Not seeing any. I would welcome a motion to conclude consideration of Chapter 29. Moved by Mr. Nerline. All agreed. That's carried. I'll turn it over to the provincial auditor to focus on Chapter 22.
Chapter 22 of our 2021 report, Volume 1, on pages 241 to 254, reports the results of our first follow-up of the Saskatchewan Health Authority's actions on recommendations we made in 2018 about processes to provide timely access to mental health and addiction services in Prince Albert and surrounding areas. By January 2021, the Authority implemented 5 of the 10 recommendations we made in 2018. We found the Authority implemented a provincial integrated health record system and a level of care assessment tool for outpatient mental health and addiction services. The Authority also enhanced monitoring of wait times for access to outpatient mental health and addiction services. We found the Authority put in processes to improve the proportion of clients showing up for scheduled appointments and documented discussions with addiction clients about the post-detox support available to them. However, we found the Authority is not effectively documenting its follow-up with clients who have missed their scheduled appointment or treatment. We tested 30 clients and found 5 client files did not have documentation that any follow-up occurred with the client. Timely follow-up to assess health status can avoid future hospital visits and reduce overall costs to the client and the healthcare system. The Authority has not formally assessed whether mental health and addiction services are meeting client demand in Prince Albert and surrounding area. It continues to struggle to provide mental health outpatient services in a timely manner. For example, we found more than 90% of children with moderate acuity level had to wait more than 20 business days to see a psychiatrist for their first appointment in 2019-20, a 10% increase from 2017-18. Not doing a comprehensive reassessment of client demand relative to mental health and addiction services available increases the risk of not providing those with mental health illnesses and addictions with timely access to service. Long waits can lead to people's health condition getting worse, and in some cases, long waits can even contribute to death. We found the Authority has yet to develop a strategy to collect key mental health and addictions client service information in its health record system from healthcare professionals outside of the Authority, for example, psychiatrists. Without a strategy to share and capture information on all mental health and addiction services provided by healthcare providers, the Authority does not have a complete client history of services. A complete client history of services provided and their impact on patient health would aid all healthcare providers in determining appropriate courses of action for patients. While the Authority implemented a community support team to support mental health and addictions clients with complex needs in their community, the Authority has not improved the hospital readmission rate for mental health patients since our 2018 audit. That is the average readmission rate of around 10%. We found the community recovery team has not yet developed any measures to gauge their success. Finally, the Authority has not made progress in collaborating with the Ministry of Social Services to enhance access to housing options for mental health and addiction clients. Having organizations work together to provide stable housing can lead to better outcomes for people living with complex mental health and addiction issues. I will now pause for the committee's consideration.
Thanks so much for the presentation and such an important focus. I'll turn it over to the Deputy Minister for remarks, and we'll open it up for questions.
Okay, so the first recommendation on page 243 is not implemented. Mental health and addiction services, patient demand, caseloads, and appointment supply are reviewed on an ongoing basis. More work is needed to fully leverage the reporting features of information systems to better understand service supply in relation to demand. Progress on this important work has been delayed due to recruitment challenges as well as a necessary focus on the pandemic. Recommendation number 2 on page 246, the auditor has noted this is implemented. Recommendation number, recommendation number 3 on page 246 is not implemented. There is provincial work occurring regarding the integration of a provincial health record that will be inclusive of mental health and addiction client information. Recommendation number 4 on page 248, as noted by the auditor, is implemented. Recommendation number 5 on page 249 is partially implemented. The SHA Communication Recovery Team is tracking client episode of care for approximately 25% of clients to better understand client needs. Once data collection analysis is completed, the SHA will use the information to better serve their clients. Recommendation number 6 on page 250 is not implemented. Work to implement the recommendation is ongoing. Due to the COVID-19 response, no further provincial work has occurred with the exception of the assisted self-isolation site work. The pre- and post-treatment beds and residential support beds for this area are set for implementation on March 1st, 2022, and the SHA is involved in a homeless research project where a number of community stakeholders, inclusive of social services and health, are present. Recommendation number 7, as the auditor has noted, has been implemented. Recommendation number 8 has also been implemented. Recommendation number 9 on page 252 is partially implemented. Work standards are developed. There's consistent practice of documentation regarding follow-up when clients do not maintain a scheduled appointment. Management will develop monthly audit metric and processes to ensure measurement improvement regarding consistent documentation. Due to the COVID-19 response, the rollout of the standardized suicide protocol process in mental health and addictions information system and accreditation and the audit work have been delayed. SHA intends to have the new processes fully implemented by 31st of December 2022. And lastly, on page 253, recommendation number 10 is implemented.
Thank you for the report. I'll open it up to the table for questions. Ms. Ritchie.
Thank you, Mr. Chair. It seems there's quite a few recommendations stemming from this audit, and that are yet to be implemented still. I think on the first one regarding assessing whether mental health and addiction services are meeting client demand in its Northeast Integrated Service Area. I believe I heard you say that there were some recruitment challenges. Is that correct? Yes. Okay. Yeah. I just wanted to clarify that. So, yeah. I mean, I can appreciate that. Wait times are being monitored, and you're exploring options for increasing access in response to growing time. And if recruitment, maybe you could just speak a little more to the recruitment question. What's driving that? What's getting in the way of recruitment?
Andrew McCletchie, the Vice President of Integrated Northern Health. I think that there's probably a number of factors. I think just provincially, there's sort of been a shortage of nurses and social workers with mental health training. And so, in a sense, those staff can go wherever they want in the province to be employed. And so it's resulted in difficulty with recruitment as well as a degree of churn. And I think in some ways we've also, through the pandemic, created positions that staff could apply to in temporary or temporary positions they could apply to. And so a number of staff have chosen to do temporary roles, which added to some of the recruitment challenges.
And what is the current vacancy level then for these positions?
Do you know, I don't have that information with me, but I can get it for you.
Okay, yeah. Well, similarly, it would be useful to know what sort of counseling wait times you're experiencing as a result.
In terms of wait times, I kind of, in a sense, don't have the actual wait times, but I have information that basically talks to wait time per assessment. And for a number of the different targets that we have, so this is kind of looking at kind of severe or very severe clients being seen immediately, severe clients being seen kind of within a number of days, moderate clients being seen within 20 days, and mild being seen within 30 days. And basically, we are seeing our child and youth addictions clients that need to be assessed within that target. We are seeing adult addictions within targets, with the exception of moderate clients, where 41 of 47 were seen within the 20 days. For child and youth mental health, and these are information from the past year, we weren't meeting the target for severe, where one of our clients wasn't able to be seen within the time frame. And for moderate, 2 of our clients, 15 of the 17, were seen within the appropriate time frame. And then for adult mental health, for severe and moderate, we also weren't meeting the 100% targets. There was one person that we didn't see who was listed as severe in adult mental health in the past year within the target. And there was 9 people that were moderate and that weren't seen within 20 days.
When you talk about options being explored for increasing access, can you give me an idea of things you're looking at?
For increasing access to any one of the services, or just generally access?
Let's go general.
General. I think there's been a number of different services that we've kind of looked at within the community, and a number of these are from the mental health and addictions investments in the Prince Albert area. So having things like the police and community teams, or police and crisis teams, kind of allows for a response to a subset of the population that in a sense can be assessed and responded to quite rapidly, and allows for that positive relationship with our police services. We also, in a sense, have a mental health drop-in kind of in the central part of Prince Albert that allows for kind of clients to be seen, and there are physicians and nurse practitioners at that site that support those clients. As well, there's a number of different relationships with various community programs that are being explored and built on that allow for us to broaden our service delivery and go beyond just what the SHA provides in terms of counseling.
As it relates to the CBOs, I am somewhat aware that there is a lack of consistent funding for them to be providing those kinds of services, and if that is an option that's being explored, is continuing funding also part of that consideration?
I would say one of the things that, if stepping back and looking a little bit at our CBO partners, in the space of mental health and in addictions, we're seeing them take on a growing role in that service delivery. And through many of our new investments, we have actually gone out to market to ask, some of our CBO partners, can you deliver some of our mental health beds, as an example, some of these counseling services. And so certainly they have the opportunity to come forward through those formalized processes to tell us, what is the cost of providing that service. And so we are engaging with them in a little bit of a different way where, we are looking for these services through those mechanisms, and they have ways of, telling us, what are the costs of running those programs. And so I do think that has positioned us a little bit differently, maybe, to be working with this sector. And it is something that, I think we're really conscious of moving forward. They're a big part of how our services are delivered and will continue to be. And so I think more and more we are thinking about them in terms of, what kinds of training supports, what kinds of other things might they need in addition to, some of our main delivery agents like the SHA. So I do think that from both a funding perspective, but a capacity and a training and a kind of clinical perspective, they really are on our radar, and we're looking very much to kind of strengthen those relationships. And I know, when you hear us talk about health networks, certainly the SHA has a strong commitment to delivering service through the network model, which really contemplates strong partnerships between CBO organizations and other delivery agencies. So I think that has been maturing over time. Always some ways to go, but we do consider them a really valuable partner.
Yeah, and I think that, I guess my next question would be, are you consulting with them on program service delivery support services, et cetera, as part of that sort of maturing relationship?
Yeah, I can let Andy speak to how that unfolds at the local level, but certainly, when we undertake provincial initiatives, there's different mechanisms of engaging with them. We use things like market sounding, or we have them represented on a number of our different strategy tables. The Pillars for Life, as an example, we'd have, partners from the community there. So we have lots of different mechanisms of engaging those partners and really trying to understand what role they can play and how they can be successful in doing that. Having said that, Andy might have more to share in terms of how that unfolds at the local level.
Yeah, and I think what I'd add is adding to what Billy Joe had said around network development, that really within the networks across the Saskatchewan Health Authority, our mental health and addictions leaders and our primary healthcare teams do reach out to the various partner organizations depending on what projects they're working on. So an example in PA, one of the recommendations was around housing. And I know that our mental health and addictions team has had a lot of discussions with numerous community partners around what's feasible or what are the opportunities that can be explored for improved housing for at-risk populations in that community. And in a sense, those relationships don't always result in perhaps an action, or it may not be the right time for some of these NGOs, but it is something kind of where they have a lot of advice and support that they can provide that then can be built into future planning.
I'm glad that you're using that example, because I did have one final question I wanted to ask about that in terms of progress on housing options. It's my understanding the auditor affirms that stable housing would reduce costs and improve outcomes. So is it? Can we make housing for mental health and addiction clients a priority?
Well, I do think it's one of the directions that the province has gone in terms of looking to say what are the opportunities around housing for mental health clients and clients with addiction. And I think Prince Albert has had some challenges in finding the right community organization to move forward on that. But definitely those discussions have continued despite those challenges. And I know within the community there's a lot of groups, including the City of PA, that are very interested to see what can be done in terms of housing.
Final question related to that. I understand there had been a meeting in December 2019 between Ministry of Social Services and SHA on that topic. I assume there's probably been meetings since, but in relation to that one, can you tell us what outcomes arose from that, if anyone can recall it? I know I'm going back a ways.
I'm not sure that I have that information off the top of my head there. I know that there's been ongoing conversations with a number of different partners, and definitely the Ministry of Social Services, along with the SHA, has been working with a number of community partners. But as to the specific outcomes there, other than knowing that they continue to discuss kind of how to build options for housing, I am not aware of the specific ones from that meeting.
All right, thanks very much.
Further questions from committee members? Thanks to those that are involved in this work. I mean, it's critical in people's lives, and it's about our future, these sorts of interventions and priority that we place on these things. And I was sort of watching it as the chair here too. I sort of wanted to interject on certain pieces, but I think some of those are best left for sort of the budget debate as well, and the estimates debate and the policy field debate. But, you know, from my perspective to the province and to the, you know, to the cabinet, these are very important things that need to be prioritized and then resourced so that the good folks can get out there and the partners can close those gaps. Not seeing any further questions, I'd entertain a motion to conclude consideration of Chapter 22. Deputy Chair Young moves. Is that agreed? Agreed. That's carried, which takes us to our last item of the day, and that's Chapter 23, and I'll turn it over to the Provincial Auditor.
Chapter 23 of our 2021 report, Volume 1, on pages 255 to 260, reports the results of our third follow-up of the Saskatchewan Health Authority's actions on 3 remaining recommendations we made in 2013 about processes to triage patients in hospital emergency departments in Saskatoon. By February 2021, the Authority implemented 2 of the 3 remaining recommendations we made in 2013. Changes the Authority made: better support staff in routinely assessing patients in emergency department wait rooms, and improved patient flow in and out of emergency departments at the Saskatoon hospitals. These improvements resulted in emergency department patients seeing physicians on average sooner. However, the Authority needs to resume its work about tracking and reducing the incidence of patients who could be seen outside of the emergency department to ensure it makes optimal use of its emergency departments. Tracking the incidence of patients who could be seen outside of an emergency department provides key information necessary to formulate strategies to focus the use of emergency department resources on patients requiring emergent or urgent care. I will now pause for the committee's consideration.
Thank you. Thanks for the follow-up, and thanks to the ministry for the report on this front, on their actions. I'll welcome brief remarks, and then we'll open it up.
The first recommendation on page 256 has been implemented as noted by the auditor, as has the second recommendation on page 257. The third outstanding recommendation on page 258 around provide consultant care for less urgent or non-urgent patients outside of the emergency department is partially implemented. Comprehensive system flow initiatives are being developed in Saskatoon to address ongoing acute care capacity challenges with target initiatives in acute care, continuing care, primary health care, preoperative care, and surgery. The COVID-19 pandemic responses remain the key priority for the SHA. Therefore, targeted work to specifically progress these recommendations has not occurred. Orthopedic consults are being tracked manually and sent to the area lead of surgery. And by March 31st, 2023, the SHA will establish electronic tracking of patients presenting to the emergency department that could be seen elsewhere. I would also mention our urgent care centers, which are currently being developed as an alternative. So with that, I'll turn it back.
Thanks for the report, all the work, and I'll open it up for questions. Ms. Ritchie.
Well, thank you for that update, Deputy Minister Hendricks. Maybe I'll start at the tail end there. You mentioned the urgent care facilities. Maybe you could just provide us with a little bit of a description of that model and its current status of implementation.
The urgent care centers are being developed to meet the needs of individuals that wouldn't need the full-on response from the emergency department. They're for episodic care, and they are focused on the things that patients can come in for and be treated for and leave in a short time period. They also are looking at mental health patients, because there's a number of mental health patients coming in through the ER that may not need kind of the full-on treatment of, ER physicians and others, but need support from mental health workers and psychiatrists. So the focus in the urgent care centers is twofold. It's the individuals that don't need to come into the ER, likely aren't going to be admitted to the facility, but could get treatment and leave. I don't know, Mark, if that's what we're looking at providing. There's work underway in terms of the finalizing the plans for building the centers, and then once they're in place, operationalizing them.
I would just add that Regina is probably moving on a faster track than the one in Saskatoon, just based on land selection and the identification of where the urgent care center will be located in Regina, and that's not yet been determined in Saskatoon.
Have you identified the number and locations? Apologies if I don't know these details myself already, if they're already been publicly reported, but...
in Regina, and that location has been determined, the one urgent care center in Saskatoon, and we're still working on the location.
So 2 in total that are planned and in development?
Correct.
Yeah? Okay. So how does this relate to service in rural areas outside of the 2 major cities?
I guess I would say, for residents of rural Saskatchewan who would consider Regina to be their, within the Regina or Saskatoon catchment area, and would consider those centers to be the locations that they would travel for emergency or urgent care, or in some cases care that would not be available through a family physician, either because of the hours of service for a family physician or a local health clinic in their community, or just it may well be a service that's not available. The urgent care centers would provide an alternative to an emergency room, whereby rather than presenting to an emergency room with what would be considered to be a lower urgency visit to an emergency room, without getting into the whole CTS assessment system, but you do have different levels of urgency by which emergency patients are assessed on presentation. This is really targeting some of those low urgencies, the CTS 4s and 5s, probably more significantly. So that patients who would be potentially seeing an emergency room as their best option for a low urgency, as Sharon mentioned, episodic type of an event, that they would have the alternative of the urgent care center as a place that would both be provide a more appropriate level of service. Many of these individuals don't require an emergency room and an emergency physician to do their assessment and treatment, and this would provide both in a more appropriate setting for them, but also, from a system perspective, removing some of the demand on the emergency department, so those who do have more serious, more urgent types of conditions, will hopefully be seen more swiftly in the emergency department, and sometimes those patients will spend, the low urgency patients who come into emergency departments are triaged as such, and sometimes they'll spend many hours sitting in the waiting room, sitting beside people who are in distress, sitting beside people who may have something that could be contagious, and so trying to also remove that part of the healthcare experience for people who are really just trying to get a broken ankle set or casted or something like that.
Yeah. I guess as I think about those kinds of services that traditionally or historically people would approach emergency rooms about. I wonder also what how you're going to sort of educate and so people understand and how they can even make that determination, so they know to go to the urgent care versus an emergency room.
There will be a lot of communication about what they're intended for. There also will be built into the plans a capability to respond to whatever emergency comes in the door, because people may not get it right. And we've done a lot of evidence review from other places that have urgent care centers about what the challenges are and what we need to be prepared for when we open. And we know that it will be there will be learning in the initial phases, and people will to land it right, but we'll need to be able to be prepared to respond. And then we have ambulance and other support as needed if we need to transfer individuals. Just in terms of the rural areas, there is emergency care available in rural hospitals around the province, and the urgent care centers aren't meant to replace that. Those services we'll continue to manage and support, and the SHA is working hard to stabilize those services.
Can you tell me about the staff complement to staff the facilities? Will those be new FTEs, or will they be redirected from other parts of the authority?
It's my understanding there'll be new FTEs, new staff, new positions.
Can you tell us how many? Has that been identified?
Not identified yet. It's too soon in the process for me to be able to respond to that.
So going back to I assume this is the facilities themselves, or you're working with SAS Builds to develop. So what stage of development are we in right now for Regina and Saskatoon?
Regina site, I think we're at the point of finalizing the plan, but maybe you can get a better, we work with the ministry, SAS Builds, and the SHA to finalize all of these, so yeah.
Chair, as mentioned, we are working in 2 locations, one in Regina and one in Saskatoon. We're a little further ahead in the Regina location, and so we have contracted with the building constructor, and so work is underway to get that project fully designed and started. In the Saskatoon case, we are still working through site selection and working through a number of different factors around finding the site that will work best for this particular project in that location.
Now, I think you mentioned the contractor has been selected. Can you tell us which firm has received that?
I would like to, but I cannot recall if we've made that fully public yet. So I'll maybe just reserve that, and for certain we can share that with the group when it's be made public. Apologies, I just can't recall. I don't have the note in front of me.
What sort of contract model are you using?
Oh boy, I think it will be a design construction model. Yes.
Will there be any sort of a partnership PP3 model?
Thank you. No, so the SHA will own and maintain the building once it is constructed.
Thank you very much. No further questions.
Thanks for the questions. Thanks for the work on these fronts. Any further questions from committee members with respect to Chapter 23? Not seeing any. I'd welcome a motion to conclude considerations. Mr. Scoropad moves. All agreed? That's carried. Just to the Ministry of Health and the Saskatchewan Health Authority and all those out on the front lines and all those professionals and all those that are connected to the work that we've been talking about. Thank you so very much for your service, for your work, and you've come through and continue to endure the consequences and challenges of a pandemic, and we thank you for that service and for that leadership. Every last worker on the front lines through to leadership. At this point in time, I would welcome a motion to adjourn. Moved by Deputy Chair Young. All agreed? That's usually the most popular motion of the day. That's carried. This committee stands adjourned until 8:15 tomorrow morning.